just if I do get any interruptions, apologies for that. It would only be in an emergency circumstance. So hopefully there won't be any disturbances for the next hour or so. So yeah, I'm Lucy Blunt. I'm a GP in Leamington Spa in Warwickshire, and I'm leading on our Midlands Perinatal Mental Health Training project that's been ongoing for about the last 2 years. The plan for this training project was to really try and upskill everybody in primary care on the awareness of perinatal mental illness and how best to manage that and treat it within the community. So over the last 12 months, we've been going around doing quite a lot of training, and you may well have already had some talks from your local champion, but we just wanted to do an update and do a little bit more teaching about sort of the medication and management side of things. So I'll get started if that's okay. She says with the presentation now not working. Has the slide moved on at all?
Oh, I think it's still the main one for me, the first one.
Okay. Is it now on the title slide? Perinatal
Yes.
mental health update. Lovely. Okay, so I think it is working. So before I get started with any real content, I just wanted to put a little warning shot out. Obviously, we will be talking about things that are quite sensitive. So feel free to kind of take some time out or switch off if you're struggling to cope with any of the content that we talk about today, because we are going to be discussing mental illness, traumatic births, suicidal feelings, and domestic abuse. And I think it's really important when you listen to talks like this to just think about your own experiences and what you've gone through, either as a parent or as an auntie or uncle or grandparent or sibling, when it comes to the birth of a new child into the family, because I think that really frames how we approach some of these patients. The other thing I just wanted to mention is that we recognise that whilst not everybody would identify as a woman or a mother, we will be using those terms within this talk just for simplicity. So I hope that doesn't cause offence to anybody. So briefly, we're going to talk about what is perinatal mental illness, how common is it, what are the consequences, how can we manage it better and what's preventing us from managing it well, how can we encourage kind of open conversations, and how can we support individuals and families that are affected by what can be a very tragic condition. And then we'll talk a little bit about prescribing and medication management and hopefully have some time for questions and feedback. So I guess the first thing to say is, what is perinatal mental illness? Well, this is any mental illness that develops for the first time. And I think that's really important. This isn't somebody who's already had a mental illness. It's something that's occurring for the first time in a woman who is pregnant from the time of conception up until the child's first birthday. And what we know is that this affects 1 in 5 women and actually also 1 in 5 men, which until very recently hadn't been talked about. And it includes psychiatric conditions that can occur at any other time of life, so things like anxiety or depression, but it also includes the specific conditions in the perinatal period, which are perinatal OCD, perinatal PTSD, and most tragic of all, postpartum psychosis. And the reason that we're talking about it and the reason that this whole project exists is because these conditions are common, they're serious, and they're being missed. And it was very much an NHS England initiative to try and very much upskill everybody in primary care so that we were managing this much better. For me, my passion for this topic came from devastating circumstances, in that I lost a very close school friend about 6 years ago now, who took her own life 3 days after the birth of her baby as a result of postpartum psychosis. So I have a very close connection to these conditions. I really want to see us managing this better, and I hope that passion comes across in the presentation today, because this is really common. So obviously postpartum psychosis, thankfully, isn't as common as some of the other conditions, but it's still affecting nearly 1,400 women each year in England. And if you look at the other illnesses, again, sort of chronic serious mental illness is similarly affecting women, but some of the others, you've got 20,000 women affected by severe depression or post-traumatic stress disorder, 86,000 affected by mild to moderate depression, and 154,000 affected by adjustment disorders and distress. And these are probably the low-level patients that may not even come your way, but are out there in the community, not necessarily getting the help that they need.
Lucy, I'm sorry to interrupt. Are we still on slide 1? Because I don't think we've moved on.
Oh no, we're not. Oh gosh. Okay, I'm so sorry. I don't quite know why this isn't working. I'm going to just stop sharing and try and share again in a different form. Because it really is important that you can see the slides. I'm so sorry about this.
Okay.
I'm going to try it from a slightly different angle. Nope, that's not working either.
Has Louise got your slides? Could she share them for you?
I did send them, but I don't know. I did get a message back to say that that for some reason it hadn't reached you. This has never happened before. I'm so sorry. Honestly, this is
Okay.
really not very good at all.
It's very kind of you not to let us down when you've got a poorly child at
No,
home. You've probably had
yeah,
no sleep either. That's what
no,
needs to happen.
I'm sorry. I don't know why this isn't working. It's I don't know why sometimes it does this, because it's never ever been a problem before. I
don't know if Louise is still on the line. Excuse me, I'll just try and phone her.
Yeah, I'm here, Sheena. If you want to, if you can quickly send them to me, Lucy, I will be able to share them on your behalf if you wish.
Okay, let me just try one more time and see if it's going to play.
It's still not on a screen, a slideshow. It's still on slide 1 with the little ones, the thumbnail ones down the side.
Okay,
right. There we go. That's better. We're on slide 2.
Okay.
But it's still not a slideshow, but at least we're on to the one with the sort of
let me go to where I was.
Picture.
So can you see this about saying that it's common?
No, we're still on slide 2, I think.
Oh my goodness, I'm so sorry. Has it moved on at all?
Not for me.
No.
Oh, there's moving on. We've got hormone levels during perinatal period now.
Yeah. Okay, so that's gone too far. Can you see this one that says depression, the most common major health complication of maternity?
No, I'm still on hormone levels.
Okay. What I'm going to do is I'm going to come out and I'm going to try and send it to you.
We do have it now. The depression one has come now.
Oh, okay, that's interesting. It seems to be when I go into present mode that it goes away. So you can see that slide, can you now? Depression, the most common.
Yeah, we
major
can
health. Yeah,
we can see that.
Okay, let's try carrying on from here then. I'm so sorry that you've not been able to see the slides so far. But essentially, I'll if I go back, can you see that one that says it's common?
Yes.
Perfect. Okay, I'll just do it manually. So that was the slide just showing obviously the prevalence data. But what we know then is that depression is actually the most common major health complication of during maternity time. I think we're very good as clinicians within primary care, particularly at picking up things like diabetes, hypertension, preeclampsia, checking urine. But what we're not so good at is detecting the mental illnesses that are out there. And you can see how significant they are compared to some of the physical complications. So HICs are high income countries, which we are classed as, and you can see that huge discrepancy there between the mental and the physical. And it's hardly surprising because obviously during the perinatal period, the hormone levels are changing hugely. So during that first and second trimester, you've got the gradually rising progesterone and estrogen levels, which peak then at birth, but then fall rapidly straight after birth. And therefore, it's no coincidence or surprise really that we are going to be experiencing some mental health hormonal changes during this time. So not only is it common, but it's serious. What we see is that 23% of deaths are actually related to mental health causes. So that's almost a quarter. And 1 in 7 of those women within that 23% are dying from suicide. And this is recent data. This is within the last couple of years. And this just should not be happening in 2025. And what's really worrying is that if you compare the data now compared to back in 2017 to 2019, actually, women are even more likely to die by suicide during or up to the 6 weeks after the end of pregnancy. So something somewhere is not working or is going very, very wrong. The other thing is that we're missing quite a lot of mental illness. So we know that from the data that only 40 to 50% of perinatal depression is recognised clinically. And of those that are recognised clinically, only 50% are actually getting adequate treatment. And the reason for that is multiple, but we know that there are significant barriers to people presenting with illness and actually the diagnosis being made. And there was an NCT project quite a few years ago called The Hidden Half, which tried to address this and said, you know, we are missing half of the women that are affected by these conditions. And this is particularly important in the vulnerable groups. So these are women experiencing domestic violence, women affected by substance misuse, women from BAME groups, or young women, so those in the teenage years, they are particularly affected. And some of the statistics from Embrace, which look at data across all sort of maternal health, including mental health, is showing that more women from deprived areas are dying, and this continues to increase, and we need to do something about this. So just thinking about the actual illnesses themselves, you may sort of only really be aware of postnatal depression. It's the one that most people say when I say what is perinatal mental illness. And of course, as I've said, postnatal depression is an issue, but these other conditions are much more common and in some circumstances much more devastating. So adjustment disorders, going back to that slide, you know, sort of 156,000 women a year are affected by this. It's the most common type of perinatal mental illness and affects up to 30% of women, and includes difficulties with bonding and attachment. And I think this perception that women will just fall in love with their baby straight away is so false, because we know that actually that only happens in about 40% of cases. So these are normally fairly mild perinatal mental illnesses. And as I say, there's probably a lot of this out there in the community that we haven't picked up on yet because we probably haven't asked the right questions. Then there's anxiety, which affects 10 to 15% of women. Now, this can be both antenatal and postnatal and might not necessarily present as traditional anxiety like you might see in other cohorts. So this might present as people who are very nervous, on edge, uncontrollably worrying about things, or simply just can't sleep, or irritable, coming in with lots of physical conditions like chest pain, palpitations, abdominal pain, or just repeatedly coming in with things that apparently seem to be quite minor. Then, of course, there's depression, which we are probably a bit better at recognising. This affects sort of 10 to 15% of women, but about 3% are affected by really quite severe depression. And what we need to differentiate this from is the baby blues. I think lots of women have been told in the past, oh, it's normal to feel sad or down or low after your baby's born. Yes, it is, potentially within the first couple of weeks, but this gets better. And it's not the same as postnatal depression, and actually is affecting sort of 50 to 80% of women. So very common, but tends to get better and shouldn't be persisting, certainly by the time they come to you at their 6-week check. Then there's perinatal PTSD, so post-traumatic stress disorder. Again, you might be more familiar with this in other conditions. This affects around 3% of women and can arise from objectively traumatic experiences, but also can come from experiences which others might perceive as not being really traumatic. So it's really important to have a very open conversation about the birth and what happened, because something that you might perceive as not that traumatic might be to that woman who's gone through it. And this often presents with sort of vivid, distressing thoughts, reliving or playing back labour, delivery scenarios, having nightmares, sweats, panic, nausea, these physical symptoms, or just being very hypervigilant. And then there's perinatal OCD. And I think we are guilty of sometimes thinking of OCD purely as being people that wash their hands frequently. And it is so much more than that. And interestingly, this is more common than postnatal depression in some women. And they get frequent and very distressing, intrusive thoughts. So they're thinking about accidentally harming their baby, or even in worst case scenario, deliberately harming their baby. And these are not thoughts that they would ever act out. These are distressing thoughts that come into their mind. And these are probably the women that you won't see very often, because they just simply can't open up about these intense feelings that they're getting, because they're associated with so much guilt. Thoughts about potentially pushing the pram into the road or dropping the baby down the stairs. And these are so distressing for them to talk about. The main reason being that if they are honest about these feelings and talk about them, then there will always be this concern that what if my doctor or my midwife, tells social services and my baby will get taken away? And that is the biggest reason for people not opening up about these sorts of feelings. And then lastly is postpartum psychosis. Now, thankfully, this is incredibly rare, but very serious, and affects 0.2% of women. What's really scary about postpartum psychosis is that 50% of the women affected by this condition have no previous mental health history. So what we do know is that those who have bipolar disorder are at very high risk. So 1 in 5 women affected by bipolar disorder will go on to develop postpartum psychosis. So that needs to absolutely be at the back of your mind when you're consulting with women with bipolar disorder, when you're thinking about contraception or family planning. This is a condition that comes on very rapidly within the first week of delivery. And you can see, if it's big enough for you to read, the slide showing kind of the middle of the graph is birth, and before and after that is the antenatal and the postnatal period. And it is most common for this to present in that first week after birth. And this might present in a very bizarre way, with hallucinations, delusions, confusion, just bizarre behaviour, potentially suicidal ideation, or very strange feelings towards the child, not wanting to be near the baby. Often relatives are very concerned that there is a change of personality. The person may have completely lost insight, and they can deteriorate rapidly. So these are the cases that you really need to have your radar open for and think, actually, what is going on here? This is way more than just a bit of depression. So what are the risk factors for developing any of these conditions? Well, probably seem quite obvious, but a previous mental health issue will obviously put you at higher risk of developing a mental illness during pregnancy. It might be a different mental illness to what they've suffered with from so far. Substance misuse, domestic violence, I've mentioned, that lack of support from surrounding family or friends, being separated from their partner, being a lone parent, unemployment, lower socioeconomic status, or first pregnancy. And that statistic is quite staggering, that 35% of first-time parents are affected by these conditions. And we talk about this toxic trio of somebody who's perhaps had previous mental illness problems, who then goes on to develop substance misuse and is in a domestic violence situation. This is really, really dangerous, and these women are very, very high risk. So why do we need to recognise it? Well, lots of reasons. Because the impact of untreated perinatal mental illness on the mother is devastating. So emotional distress, there's an increased risk of adverse pregnancy outcomes, there's an increased risk of future mental illness, and this highest ever lifetime risk of developing a psychosis, and serious injury, and of course suicide, which I've already mentioned. So early identification and timely, high quality support genuinely does does save lives. And I think it's not very often in general practice that we can say that we save lives, but picking up somebody who is either in an acute postpartum psychosis episode or suicidal from a postnatal depression really will save a life if you can pick that up and treat it appropriately. There is also the impact on the child, and I think more and more evidence and research is looking now at adverse childhood events and the impact on long-term morbidity and mortality. But we know that poor perinatal mental health does lead to higher risk of adverse neurodevelopmental outcomes in the child. So this is anxiety, depression, neurodivergent conditions, impaired cognitive function, personality disorders, and even schizophrenia. So, you know, we really need to try and look after not just the mum for herself, but also because the impact of not treating that mum and getting her well will have an impact on the child. Also on society, untreated perinatal mental illness cost to society is in excess of £8 billion per year. And I think if there was a physical illness that was costing society this much, we would probably be much more proactive about managing it. We'd be talking about it a lot more. Interestingly, 72% of these costs are spent on supporting actually these adverse outcomes in those children who are affected. So whilst the majority of it is being spent on those children, there is a huge proportion also at cost to society for the mother herself and also the wider family and the partners. So, you know, early intervention really is effective and reduces impact. And we know that 90% of families affected can be supported in primary care. I think gone are the days where, you know, you sort of see someone and you think about postnatal depression and you just immediately refer to the local perinatal mental health team if you've got one. They are inundated and of course want appropriate referrals, but there's so much more we can be doing in the community. We mustn't also forget the partners. I've mentioned that briefly, but if the mother has a perinatal mental illness, the partner is 50% more likely to experience postnatal depression as well. And, you know, becoming a new parent is an incredibly challenging time. You know, there are financial pressures, lack of sleep, change in relationships, impact on siblings. So we must also think about the partners. So why are we not detecting these people? Why are they going unnoticed? Why is there still this hidden half? Many factors at play. I think from a mother's perspective, there is a huge amount of stigma around mental health. I mean, there is generally in lots of mental health conditions, but there's a real lack of knowledge about how common these conditions are. So, you know, they often will feel like they should be joyous and, you know, celebrating this new birth because it's what they've always wanted, or, you know, they've waited 9 months and they should be happy that they've got this happy, healthy baby. But the truth of it is that it's much more complicated than that. Anyone who's become a parent or knows someone who's become a parent, it's an incredibly challenging time. And I think sometimes the education just isn't there in letting people know how common anxiety and depression can be. So they don't recognise it, they don't come to us and talk about it. And they're also worried about talking about it because they're worried that, you know, potentially people will judge them as a parent or refer them to social services. And in some cultures, women have even explained that postnatal depression doesn't even exist. There is no word in their culture for this. And we really need to try and move away from that situation where people can't even talk about it openly. The clinician factors are so important. If we don't know it exists, how can we possibly ask the right questions? So this is a, you know, sort of unconscious incompetence potentially on a clinician's part. If we're not asking the right questions, we won't get the right answers. And this is why NHS England are really trying to increase the education in this field so that we are asking those right questions to make people talk about these things. We're also busy, aren't we, in primary care at the moment? There's 101 things that we should be doing. So many forms to fill in, boxes to tick. But with perinatal mental illness, it's sometimes about just sitting back, taking away those questions in terms of tick box exercises and talking to the patient and having a really open, honest conversation about how they're feeling. The system doesn't help. We don't have enough funding to do this properly. The interprofessional communication has gone. So I used to have midwives that were down the corridor from me that I could easily pop in and speak to and say, I'm worried about somebody that I've seen. And there was much more joint up working. Unfortunately, that and time pressures mean that that continuity of care perhaps isn't there some more, which is unfortunately very sad. But society plays a huge part. You know, all you've got to do is look on Facebook, Instagram, Snapchat. It's all about being a mother and a parent being so perfect. Lots of unrealistic video clips or adverts for things that, you know, feed this belief that becoming a parent and mothering is so natural and normal and easy, and, you know, this whole perception that you can have a successful career and a relationship and run a household and have 3 kids, and, you know, it's hard work, and I think we need to start being a bit more honest about that. So I think what's really important is when you see somebody in clinic in your setting and you're worried that there might be something like this going on, make sure that you're really having an open conversation. Listen for those non-verbal cues, look at the face, avoid normalizing. I think too often people are told, oh, it's normal to not have any sleep when you've got a new baby. Yes, potentially it is, but not if you're a mother lying awake, worrying at night with palpitations, despite your baby being asleep. So, you know, empathize, but don't normalize is what I would say. And if somebody does mention to you that they're struggling with a mental health problem, take it really seriously, because very, very rarely do people openly come out and say that. So we say that disclosure is actually a really big red flag for people that are struggling. It's probably taken them quite a long time to come here and talk to you about it. And some of the phrases that we try to encourage are more open questions. So things like, tell me about the birth. How are you finding being a mum? Rather than saying, how are you doing? Is it okay? They'll just say, I'm fine. So, you know, have you had new feelings or thoughts that make you disturbed or anxious or distressed? You know, are you struggling to sleep when baby is sleeping? Are you feeling incompetent or that you can't cope? These sorts of questions, really trying to open up what's going on behind closed doors. And then based on those questions, you can make a judgment call in your mind about how seriously you think this person might be affected. You know, are they doing okay generally day to day? And, you know, they're just mildly struggling with some low level mental illness. Or are they feeling quite down, but never really down enough that they'd ever hurt themselves or anyone else? Or has it progressed to them actually feeling like they might harm their baby? Or have it got to the point where they feel like they actually can't keep their baby safe? And at each stage of this assessment, you need to decide how seriously you need to act and what management you would need to consider. And we'll go on to talk about that in a minute. So one of the big changes that happened in 2020 was within the GP contract, triggered by some work done by Healthwatch, whereby £12 million was added to the global sum to make sure that the 6 to 8 week check was done with a GP and that this was mandatory within the contract. And that was to include not just the physical assessment, but the emotional assessment and the mental health assessment. I don't know which systems you use in your area, but we use EMIS, and certainly there used to be no mention of any mental health assessment done within the 6 to 8 week check in primary care, and hopefully this NICE guideline has triggered lots of change for that, and this new, you know, suggestion that these checks should be done by a GP. I know that in some practices they are done by practice nurses, and I think if you're a practice nurse that's had specialist training, then that's absolutely brilliant, but the NICE guideline does state that it should really be carried out by a GP, and the main sort of take-home messages about this being a quality, meaningful conversation during that check, rather than giving someone the Edinburgh postnatal depression score and asking them to just tick some boxes, because actually people often aren't honest in those sorts of questionnaires. And I think what's also reassuring and pleased to see is that for medical students now passing through university, as part of their medical licensing assessment, they also are being asked about postnatal mental health and the mental health component of the postnatal consultation. So there is some progress. We are improving and we're moving forwards, but it's probably just not enough as yet. I think the other factor I just wanted to talk about was sort of preconception counselling. I mean, I've touched on bipolar disorder and how common postpartum psychosis is in these women, but anyone with a background mental health condition is more at risk of developing worsening mental health during the perinatal period. So what we want to make sure we're doing is trying to avoid unplanned pregnancies. And I think this statistic is staggering. I'm a coil fitter and a family planning doctor as well. And I cannot believe that 45% of pregnancies and a third of births in England are unplanned or associated with feelings of ambivalence. So this means that women are proceeding with pregnancies that perhaps they wouldn't have necessarily planned. And so you're already starting out from a difficult point. And we know that those unplanned pregnancies are even more common in those women who are high risk, so those with background mental illness or other comorbidities, those who smoke, who are obese, using alcohol, etc. So really important in not just the 6 to 8 week check to talk about this sort of thing, but in your contraceptive counselling. So, you know, with your practice nurses, are they asking about in contraception, you know, have you got any mental health conditions? If so, should we really be getting you onto a form of contraception that is very reliable, trying to move towards LARC methods, coils, implants, injections, so that we really are trying to reduce that level of unplanned pregnancy within the UK, because for a developed country, that really isn't good enough. So we've talked a bit about what is perinatal mental illness, what kinds of conditions are we thinking about, why aren't we picking them up, what could we be doing better? And then I think it comes on to, well, one of the reasons why we perhaps aren't asking about it or picking it up is because we don't really know what to do if we find it. One GP said to me at a teaching session, well, postnatal depression, that's just what the health visitor sorts out, isn't it? Absolutely no, it is not. We all have a part to play, everyone within the whole team, within primary care. So I thought we'd just touch on some management options with some chat about medication at the end, because I think that's the topic that most people find quite difficult. But there are lots and lots of management options for women with perinatal mental illness. So they range from sort of self-help to those women who have just a very mild low-level need, to social support, peer support, psychological support, pharmacological support, so in terms of medications, and if needed, a perinatal mental health referral. All of this will depend on the severity of their illness and what your existing support structure is locally. As part of our Midlands Perinatal Mental Health project, we have our own website. The link is just below on this slide, and what you'll find on that website is, if you click on your area of Staffordshire, there is a whole load of resources that you can access, which will detail all of your local perinatal mental health resources and referral forms, plus lots of local charity organisations, peer support, etc. So if you're ever stuck and you don't know where to go, all of that information is there. Within our locality, we have a traffic light system. So this is what it looks like if you went onto our, so I'm based in Coventry and Warwickshire. If you went onto our Coventry and Warwickshire page, you would see that this is our pathway for clinicians, where it sort of does a traffic light assessment based on need, from green, green plus, amber and red. And within each of those sections, it gives all of the organisations or contact numbers or support systems in place that might be appropriate to women of that, who are within that assessment level. You may well have something similar in your locality. I'm not sure, if I'm honest with you, but if you have a look on the resources section of our website, if it is there, it'll be on that part of the resources. So in terms of self-help, I think it's really important to understand your local voluntary care sector offer and what self-help options are available. NHS talking therapies are trained in perinatal mental illness, so they're a brilliant first port of call. Hearts and Minds Partnership is a national website where you can go on and find out what resources are available within your locality for parents and professionals. You simply just search by your postcode. Within our region, we have NCT Parents in Mind, and we also have a local charity called By Your Side, who provide peer support. For those of you who've never heard of peer support, it's not something I was really aware of until I did some more learning in this field. But peer support is basically when people use their own experiences to help each other. So women who provide peer support are those who've been through perinatal illness themselves and got better. And the evidence shows that these women, when they are trained to become peer support workers, have incredibly positive outcomes when they're matched with somebody who is unwell. And I think that is purely about the fact that these women have been in each other's shoes and they know what it feels like, and they can be a real positive reinforcement of the fact that people can get better. And recently, the Royal College of Psychiatrists have recognised how important peer support alongside professional support is for women who are experiencing perinatal mental illness. Psychological support is obviously essential for some women, and the different techniques that can be used involve CBT, cognitive restructuring, EMDR. Some may just require relaxation exercises or counselling. But then there is also something called video interactive guidance, whereby mothers and their infant or young child are observed interacting with each other, and it's watched back by the mother with a trained VIG practitioner. And then what they're trying to do is not pick up on where things have gone wrong. This is very much a positive reinforcement exercise, is looking at where mum and baby have interacted and said, you know, look at the way that baby looked at you there. Can you see how, you know, the way you're smiling is giving you that feedback, and really trying to promote some of the positive attachments that are occurring very naturally, that perhaps when women are feeling low or guilty, they just are struggling to see the good job that they're already doing. So in terms of pharmacological support, I think this is the biggest take-home message from today. Lots of people feel very anxious about prescribing in the perinatal period. And I think it's interesting because we don't tend to get the same level of anxiety at other times of life or with other medications. You know, we think nothing of starting things like statins, and actually statins have huge amounts of side effects and risks, but we do it so often that we worry about it less. Whereas there is a little bit of bias when it comes to the perinatal period, because we're so worried about the potential impact on a developing fetus. And that's right to consider, but everyone's views on risk of illness and risk of medicine are very different. And it's really important to have that honest conversation. Also, your personal attitude to risk and uncertainty will impact on this. So if you're somebody that's not used to prescribing in pregnancy or breastfeeding, you might tend to not prescribe, whereas somebody else who's done it a lot more frequently would feel much more comfortable. So I think what we're saying here is that, you know, medication absolutely has its place, and any decision on continuing, stopping, changing or starting should really be made on a case-by-case basis when you've looked at the benefits and risks to both mum and baby. Because what evidence has shown is that if you don't treat mental illness in pregnancy and breastfeeding, the impact on the child may actually be worse than having taken the medication. And the reason for that is, if you imagine the placenta being full of all of those stress hormones, so, you know, cortisol, adrenaline being pumped through the maternal bloodstream via the placenta, that can have really, really significant mental health impact on that developing fetus. So this is about keeping mum well in the same way that you do with diabetes, hypertension. You know, you start medications to keep mum as well as possible, because if mum is well, then the chances are that baby will be well. And this cognitive bias we need to change. So if you're uncertain about starting a medication and you're worried, then, you know, learn more, read more, so that you feel more confident in helping the patient to make an informed decision. Pregnancy, we cannot confirm and guarantee that there will be a normal outcome when we prescribe a medication. But similarly, if we don't prescribe a medication, we can't confirm that either. And an unwell mother during pregnancy is just as high a risk of going on to develop more serious conditions, or worst case scenario, you know, suicide or severe mental illness. So we can't guarantee normal. What we can do is we can really try to keep mum well. We know that women who are on antidepressants during pregnancy and then stop them abruptly, either because they are worried about the impact themselves and they stop them themselves, or because they've been told to incorrectly by a clinician, have very high rates of relapse, and those consequences can be devastating. And once they've relapsed, it's very, very difficult to get them back to that good place where they were, and you end up having to perhaps give higher doses of medication to restabilize than you would have done if you just carried on. Of course, you might want to consider alternative treatment. Psychological therapy, as we've talked about, is very, very effective for mental illness in pregnancy and breastfeeding. But if somebody has tried those things and they are still unwell, then please, please think about using medication. We would want you to be using it at the lowest effective dose, to maintain the mental health. So if somebody has always been on 50 milligrams of sertraline and they get worse during pregnancy, then you might need to increase up to 100 milligrams. Similarly, if they've been doing really well prior to pregnancy and you've reduced them down, 50 might be enough, but it really does need to be considered on a case-by-case basis. And as I said before, you need to consider the risks of not prescribing and the adverse outcomes that might occur as a result. Similarly, in breastfeeding, obviously trying to give the lowest effective dose. So this isn't just giving the lowest dose for the sake of giving the lowest dose. If you're giving a low dose and the mum's still unwell, it's about giving the effective lowest dose, so you might need to increase it. Obviously, trying to avoid combinations of medication, unless you absolutely have to. But also thinking about continuing what medication was taken in pregnancy. So we tend to talk about sertraline being the most commonly used medication for depression or anxiety, both antenatally and postnatally. Having said that, if somebody's been really stable on citalopram, don't change it, because there's a high risk of you then destabilizing that person's mental health and them getting much worse. Most medications will result in some exposure to the infant through the breast milk in breastfeeding, but it's less than what we'll be getting through the placenta. So if this woman has been taking a medication throughout pregnancy and all is fine, and then they say, oh well, I'm going to breastfeed, should I stop my medication now? Of course not. If that child has been exposed to that medication in utero, then actually carrying it on in breastfeeding will make absolutely no difference. What you might want to do is ask a few more questions about things like feeding and sleeping, and just making sure that baby's being monitored a little bit more closely, just in case there are any adverse effects like increased drowsiness, those sorts of things. So as I've said, the choice of antidepressant, first line would be sertraline in somebody who'd never been treated with an antidepressant before. But if they have had something previously that's worked for them, then probably better to go for that, because now is not the time to be trying lots of different things. You want these women to get better quickly and with a drug that they know and they can trust, because I think if you've got somebody in front of you that's already incredibly anxious, first of all, trying to convince them that taking medication might be a good idea is incredibly difficult, but trying to convince them to take something perhaps they've never taken before is even more so. Specialist medications, things like antipsychotics or mood stabilizers, you would definitely need to seek advice from your perinatal mental health team. And I would urge you to do that if you're not sure. So within our perinatal mental health team, we have an advice line that you can contact if you've got somebody you're worried about and you're thinking, yes, I think they probably do need to start some medication. I'm happy to do that in primary care and monitor them, because they don't really need anything additionally from the perinatal mental health team. It's a case of just picking up the phone, having that conversation, and then getting some advice to you about medication or next steps. The one thing people always ask about when I talk about medication is, but what are the risks? What shall I tell mum in terms of them taking a medication during pregnancy? There's loads of websites that will give you the true facts. So there's UKTIS, which is the Teratology Information Service, and there's also BUMPS, which is Best Use of Medication in Pregnancy Service. They will give you all of the hard facts and the percentages and the detail, but essentially we don't have much to go on, because there aren't any trials looking at how women have responded in pregnancy and breastfeeding to certain medications. Nobody would enter that trial. It wouldn't be ethical. So all we can go on is kind of anecdotal data. But as you can see from this slide, the medication exposure and the timing can impact on the fetus. and you can see those things there. I tend to ignore this, if I'm honest, because I think if you were to go down the route of talking about this with women, it scares them a lot. But by all means, signpost them to these websites, and they can go off and have a look themselves. So as I say, Bumps, UK TIS, and then there's also the Breastfeeding Network, which has fact sheets for each type of drug. And it will tell you sort of risks and benefits and talk that through, so that women can go ahead and read this in their own time and then come back to you to have a bit more of an informed conversation. So I think, in summary, prescribing in perinatal mental illness can be daunting. You can feel anxious about it, but my take-home message is, please don't immediately stop antidepressant medication when a woman becomes pregnant, because for the vast majority of women, it is far safer for you to continue that medication during pregnancy and monitor them very closely, because in the vast majority, the benefits of taking it do outweigh the risks. I think what's really important to also mention when you're having these sorts of conversations is that these women do get better. The vast majority get very much better very quickly with the right support, with the right medication. And it obviously does depend on the type and the severity of the illness and how early it was picked up and what their previous mental health history was. But if they can access treatment early, and by that I mean good quality treatment, so that is psychological support, peer support, self-help, potentially medication, and they are, committed to getting better, then the vast majority will do very, very well. But we need to stay very positive and support them along that journey. For those women where we feel we've reached our capacity in primary care and we've tried all of the above and we still are very worried about them, then obviously we would consider a referral to the perinatal mental health team. Now, each team within each locality will have their own referral criteria. Again, you can find these on the designated part of our website for your area. But what you need to think about when you're making this referral is, what are they going to do differently? The same as we would with any secondary care referral. What am I asking them to do that we can't do in primary care? Because I think what we found in our locality was that somebody was being recognised brilliantly as potentially having postnatal depression, but the GP was just sort of sending a referral saying postnatal depression, do the necessary. Well, that's really not good enough, because for a specialist service, they need to make sure that their resource is targeted towards those who really, really need it. And there will be a triage process where they'll look at those who really need it. And potentially, that time that the woman is waiting to be assessed during that triage process, we could be doing quite a lot in primary care. So I'm not saying don't refer, but I'm saying refer those that you feel would really benefit from additional support from the perinatal mental health team, and that's routine referrals. In terms of urgent referrals, so these are women that you're worried about who are potentially experiencing postpartum psychosis or very, very serious risk of suicidal ideation or harm towards their baby. So yeah, these need immediate treatment. So we think of this as, treat this like an MI, treat this like a AAA. They need assessment urgently by a specialist within 4 hours, because this really can have devastating consequences, as you've seen from the Embrace data and the fact that we are not reducing the rate of suicide in these women. So symptoms of psychosis, significant change in mental state, thoughts or acts of violence, self-harm, or new or persistent expressions of incompetency or estrangement from the infant. These are our urgent criteria in our locality. And just remembering that, of course, bipolar disorder is a red flag. So if you're seeing somebody for their 6 to 8 week check and they've had a history of bipolar, please, please, please have this at the back of your mind. So it's a bit of a whistle-stop tour, but we've only had an hour, and obviously I had all the computer issues to get started. But I just wanted to give you some points about what can we do differently. Why are we talking about this? How can we make this better? Well, I think what we need to be doing is training all staff within the practice to recognise some of these soft markers of potential perinatal mental illness. So this is the receptionist potentially noticing that the lady in the waiting room with twins appears very distressed or distracted or is tearful. That those sorts of things, if picked up early, can have a massive difference on outcome. have a look at your 6 to 8 week mum and baby check process. Could it be better? Who's doing it? Is it nurses? Is it GPs? How much time are they being allocated? There is huge variation across the country about how much time is allocated and whether mum and baby are seen together and whether partner is allowed to come or not. So perhaps review your mother and baby check process would be a really good QIA activity for any GP registrars potentially within your practices. Make sure that in contraceptive counselling, you're really talking about mental health. And for those with significant mental health diagnoses, ensuring that you're giving them something that's going to be effective and adequate. So thinking about LARC methods, encouraging the conversation about mental health and new parents, and really thinking about signposting to support services and starting treatment early with these women. That is the key. Make sure you understand what your local perinatal mental health team can offer, how to refer to them, what their emergency phone line is, what their criteria are for urgent referrals, so that you can make sure that your referrals are timely, appropriate and detailed. Really make clear what it is you want them to do for you by being referred, and really utilise the local voluntary services. I think lots of funding is going into those sorts of services at the moment, and we need to use them, because if we don't, they'll go, and they are so valuable. I mean, for anyone who's got a social prescriber in their practice, the amount of help that we can provide to our patients within primary care via the social sector is so important. I think I've talked about most of these things, but just a few other pointers to consider. Thinking about support and safety netting at home, thinking about safeguarding elements. Don't immediately think somebody needs a safeguarding referral just because they've admitted that they're having distressing thoughts towards their baby. You know, the chances are, in the vast majority, I would say 99.9% of these women will not act on any of these thoughts. And it's really difficult to differentiate, but important, between thought and intent. And if you were to suggest to them that they would actually act out some of these difficult thoughts, they would be horrified. So please just think about some of the safeguarding elements, but not too much. And don't over exaggerate to the point where you prevent somebody from seeking advice about something that really doesn't need to be a safeguarding issue. So what now? Well, I would urge you to talk about this in your practice meetings. What are you doing well? What could be done better? Even if it's just, you take to your practice meeting, I went to this talk at PLT and the take-home message was, let's not stop medication in women who are pregnant without really thinking about it first. That would make a huge difference. For those of you that are interested, there are lots and lots of books that you can read that are really helpful to give you an insight into how women are affected by perinatal mental illness. There's a really good book by Anna Mather called Mind Over Mother. This is a really good one to help patients understand about perinatal OCD and anxiety. It sort of, I don't like using the word normalise, as I said before, but it kind of shows how common this is in women with new babies. So I will quite often signpost my patients to these books to have a read through to support them, or just for us as clinicians, health professionals, to just really understand more about what's going on in these women's minds and the kind of thoughts that they might be having. And I mentioned a couple of times about the resources. So on our website, so the reason this says Coventry and Warwickshire Training Hub is because as our training hub, we were granted the funding to host the Midlands Perinatal Mental Health Training Project. But essentially, we do have our own website. It's midlandspnmh.co.uk. And within that website, you can click on your area to find the resources in terms of the perinatal mental health referrals and some of the peer support and charity options. But don't forget also the other resource which I said, which was the national resource, which I'll just go back into, which is Hearts and Minds Partnership.org, where you can also look for resources in your area if they're not there on our website. So it's 2:27. I know I'm going to talk until potentially till 1:45, but I just wanted to end by saying, for those of you that are interested and want to perhaps learn more, learn from people who've been through this experience, go into more detail about some of these conditions, feel more confident about prescribing. We are doing some face-to-face fully funded training days this year. We have got an event in Stoke at Longton Rugby Club on the 4th of March, which currently does still have some space available. If you'd like to join us on that event, the QR code is on the screen. You simply need to fill in the registration form. During that day, we will have lived experience speakers. We will be talking about the conditions in more detail. There'll be lots of resources shared. We'll be talking about how to have difficult conversations at the 6 to 8 week check. We'll be talking about different medications and using lots of case studies to really make sure that everyone who attends that day goes away feeling much more confident about managing perinatal mental illness. So please join us on that day if you are available on the 4th of March. I think it's a Tuesday. Everyone is welcome. This isn't just GPs, it's anyone working within primary care. So feel free to share this with your teams back in practice. If you've got any colleagues that might like to come and join us on that day, you'll get a nice lunch, you'll get to network with lots of other people. And we are incredibly lucky that NHS England have funded this for us. So yeah, hopefully see you there. And I think that leaves us 15 minutes for some questions if there are any.
Lucy, there was a question in the chat a little while ago which was from Dr. Anwar, who's just asking, can GPs directly signpost or refer a new mum for peer support? And also I've put in the chat for those who can access, we've put Louise has actually, to be honest, but Louise has put the link for the sources for support for both North Staffordshire and for South Staffordshire. So that's in the chat if you can access it.
Brilliant.
And our local champion is Bala. I presume she'll be at Longton, won't she? Presumably on the 4th. Yeah. Thank you.
Yeah, and I think in answer to that, can we refer? Absolutely. To yes, please do. Please refer for peer support, because what's really interesting is that some women feel that they don't want to have this labelled as a psychiatric condition. So I had a patient who probably needed perinatal mental health support from the secondary care team, but she refused to go because it had the word psychiatry all over the forms. But she was much more open to going to a peer support group where she could meet with other women who'd experienced what she'd been going through, and felt very much motivated and supported positively by that experience of sharing her concerns with someone who'd been through it before. So I think there still is a very much a stigma, as with everything mental health related, about being referred to a psychiatrist. And the vast majority of these women, as I said, they don't need that. There are a small percentage that do, and of course refer them. But yes, absolutely signpost. I think it's so nice within a consultation to be able to say, I think you need a little bit of support. Let me send you, by Accurix, I don't know if you use that in your area, or, you know, these details. Let me send you all these support criteria, or signpost them to, websites and things. I probably wouldn't signpost them to our website because it is aimed for professionals, but you can certainly signpost them towards the local resources that you might have available to you on other, web-based sites and things within your area. But yes, please do refer for peer support, and I think let the patient do it themselves. These kind of agencies, they will accept GP referrals, but as with most of these things, if patients instigate it themselves, they're much more likely to engage because they are on board with it. So yeah, please do.
Lucy, can I ask a question, if that's all right?
Yeah, of course.
Yeah, we do have EMIS, and I agree. When I remember having a different template, because the EMIS standard 6 to 8 week check one is pretty frugal in its questions. Do you know if EMIS are going to produce a new one in line with the sort of guidance, which will have more things in it? Is that, or will we have to sort of just develop one ourselves within practice?
Well, so what's really interesting is that some of the work I did quite a few years ago was looking at EMIS and the templates. So I have actually created a template that I use within our practice that has links to our local resources within it. So, you know, within a template, you can have hyperlinks. And it even has a kind of traffic light grading to help clinicians decide, you know, the level of need, mild, moderate, etc. I don't know that EMIS have got their own. So we in our area use Ardens. I don't know if you use Ardens at all, but this is a sort of template provider that they did create one that we can sometimes use, but it's still not brilliant. So you might find, I mean, I'm very happy to share the one that I've created and then you could potentially edit it. But if you've got somebody who is quite IT savvy, it'd be a brilliant project if within your training hub, you've got sort of ambassadors or fellows that are looking for projects to try and create an EMIS template that would encompass that's sort of relevant to your area. As I say, I'd be very happy to share mine that could be edited, because I think unless those questions are part of that template, sometimes they're easily forgotten.
Yeah.
It's very easy to just kind of tick the box on the physical side of things. One of the sessions that we did at our face-to-face training days last year was looking at the 6 to 8 week check as a whole, not just the mental health perspective, but also the physical health, looking at kind of continence health and, breastfeeding and the whole picture really. And there was some work being done by Claire MacDonald, who's a GP over at working with Birmingham University, looking at this, and I think her research is going to be published soon. So I wonder, out of that there may well come something that EMIS do themselves, but I don't think it would ever have necessarily the locality based hyperlinks, but I guess you could add those yourself in the same way that we have.
My other question sort of links to your thing about accuracy. Do you think it might be worthwhile thinking about, when we get the notifications of births, having a sort of generic sort of letter we send out on accurate saying, you know, congratulations on your baby, you know, this is sort of your, you know, when we'll be seeing you at 6 to 8 weeks, but perhaps having some locality based support things that patients could access themselves, because obviously it's a big gap, isn't it, between delivery and coming home and then us seeing them at 6 weeks.
It is, and I think that's really interesting, isn't it? Because you're under the midwife and then you come out of hospital and the midwife discharges you, then you're under the health visitor. And in the old days, the health visitor would come every week for a bit, but I don't think that happens anymore. That's certainly lost in our area. So you're right, there's this kind of no man's land. And actually, if you go back to the graphs that I showed, that's when people are most at risk. And it is quite a long time to wait until the 6 weeks. So yeah, absolutely. We in our practice do a couple of things. We send a card on the birth of every baby, and we handwrite those as depending on whose patient it is on whose list, and we say congratulations, we look forward to seeing you at your 6 to 8 week check. And we also then, as part of that process, do send out a message saying this is your 6 to 8 week check appointment. If however you've got any concerns in the meantime, please don't wait until then, because sometimes, you know, the contraceptive element, we've missed that as well by the 6 to 8 weeks. So yeah, I think every practice will want to do it their own way, but yeah, I think that would be a really nice thing to do if you're not doing it already. The timing of the 6 to 8 week check is another thing that the research project was looking at, both in terms of whether 6 to 8 weeks is the right time. We've traditionally done that because it sort of linked in with baby's first IMS, but is that the right time? Should we be seeing mum much sooner than that? Should we be seeing mum and baby together, or should it be separate? And how long are we allocating for that appointment? Because I think we did a sort of a brief poll in one of the PLTs that I presented at previously, and it ranged from anything from sort of 10 minutes for mum and baby up to like 45 minutes. And that's huge variation. I mean, goodness knows how somebody felt they could do a 6 to 8 week check in 10 minutes. I think they must be, they're obviously just missing things, unfortunately, because you physically can't do that. So yeah, I think looking at the timing of it is really key. But for now, I think NICE are still talking about it as being a 6 to 8 week check. But perhaps to send those feelers out, you know, early on, saying contact us if you're worried, would be a really nice thing to do.
Thank you. Sorry, if anyone else would like to ask questions, sorry, I don't mean to take over at all. It's difficult because we're on a lot of pages to see any hands up. So I'm happy we've got another 5 minutes of Lucy's very valuable time. But if anyone wants to speak up, obviously put your microphone on.
Stunned to silence. I mean, I think it's a difficult topic, isn't it, to talk about, and I think the real learning comes from talking about it in groups. This is where the face-to-face sessions are really, really helpful, because just getting to know other people in your area as well, you know, and other resources, and talking to them about what referrals do you accept, and could I send this, or what would you do with this woman? So I would really urge people that are, you know, motivated to join us at the face-to-face day if they can do. Similarly, you know, there are other resources on our website, and I'm always happy for people to email me if they've got any queries or concerns. As you said, Barla is the champion for your area, but the funding for her kind of official role has ended now, but there is still some funding that we could potentially put on some more events in the future if that was wanted. So all you need to do is get in touch with me, and I can try and sort that out if anyone feels like they'd like something perhaps in their practice or something additional from a training perspective.
We have got one question in the chat, which was just, could you put the details for that 4th of March event up again? Would that be possible, just to put the last slide up?
Yes, let me do that now. Oh, she says, having had a nightmare trying to share previously, so I'm gonna try. Let's have a look. Can you see it?
Yes, we can. Yes, we can.
Yeah,
That's perfect.
a tiny little QR code at the bottom. We've got obviously a minimum number of places. So I would say if you're interested, sign up ASAP, because once we get to the kind of capacity, we won't be able to accept any more, but we would hold a waiting list. But we'd love to have as many of you there as possible, because we've got some really good speakers coming to talk to us.
Lucy, when you share the slides with me at the training hub later, we can put this into our weekly bulletin as well, if you would like.
Oh, fabulous. Yeah. That would be great if that's okay. Did you get the slides? Because I did send them to you, but it did come back with an error message saying that your address was invalid. It didn't work?
I know you said that you was sending them, but no, I didn't receive.
Yeah. How strange. It might be because it's quite a large file. That's the only thing. It's got lots of pictures. But yeah, I can certainly send you the QR code.
Sometimes if you make it a PDF and send it to us, then we can put that on
yeah.
the website. It's less size, isn't it?
That's a good idea. That's what I'll do.
From experience of doing this before. Yeah, no, that's really fantastic. I don't think there are any. I'm just checking the chat. I don't think there are any other questions. So we have got till 4 o'clock before the next speaker. So if people just want to, sorry, 3 o'clock.
3 o'clock.
I was going to say, oh God.
Sorry, I'm so sorry. I've yeah, my watch is in the menders at the moment, and I didn't have my phone by me, so sorry about that. Yeah, so we've got a quarter of an hour for a tea break. So if you want to grab a cup of tea, obviously, and then rejoin us then for gynae malignancies, spotting them early in primary care. But thank you, Lucy. I think that was such a good talk. And I hope your child isn't too poorly and gets better soon anyway.
Oh, thanks so much.
Right, take care, everyone. See you in a quarter of an hour. Bye. Hello, everybody. If you're just joining us back with a cup of tea after a break, if you haven't had a chance already, I know Louise has very helpfully put the feedback survey link up there again for you. And I think our next speaker, Miss Schamberg, is ready. Is that right, Smrita?
Yep. Just let me know when you want me to start.
Well, technically it's 4 o'clock. So if you want to start sharing the slides, that would be lovely.
3 o'clock.
3 o'clock.
3 o'clock.
Sheena.
Oh, sorry, I'm completely. I've got myself all in a 3 o'clock. Sorry. Yes, no, that would be perfect. And I believe you're going to talk to us about picking up ovarian cancer early in primary care.
Various gynae cancers, but more the focus is on what's current in the world of primary care and gynae oncology.
Perfect.
Can you see that? Now I'm going to start it as a slideshow and let me know if you can see it as a slideshow. Let me see. Can you see that as a slideshow?
I can't yet, but I can see that.
Is it moving?
Oh, it is now. That's now. It's now.
Excellent.
Perfect. Yeah. Perfect.
Shall I start, or do you want to give it a few minutes till 3 o'clock?
I think everybody is. It's difficult to have people back, but yeah, if it's, we should start at 3, as that's what we've advertised, I think.
I mean, I won't take the full 45 minutes or whatever I've been allocated. So,
but we have another speaker after you, so it just depends on whether they come early or not, because we've got the medical examiner coming from UNHM to give us an update after you. So, and do you want questions at the beginning or the end, or do you want them in chat and answer them as you go? What would you prefer?
Probably at the end, because then I lose my trail of thought.
Okay, that's fine.
So if I have them at the end, like I said, my talk isn't very big, but if I have them at the end, that would be good.
Perfect. Perfect.
Yeah, sadly, I'm of that age where I lose my train of thought if somebody interrupts me.
I can empathize with that, exactly.
Yeah. And I will be talking a little bit about that as well. So.
Well, I clearly can't tell the time this afternoon because my laptop's set on some other time zone for some reason. So I'm very confused.
It is 3 o'clock, is it?
It is 3 o'clock now, I think, yes.
Okay. Shall I start? And people will obviously drop in as they want.
That'd be perfect. Thank you.
Okay, well, thank you very much for inviting me to discuss this topic. It's really, you know, I feel privileged that I've been invited to speak about this, that you guys have shown interest in this, because this is a passion of mine, is to make sure that women with gynecological cancers don't get missed. And there are quite a few simple things that can be done in primary care, which would and if you're aware of them, then obviously you will consider gynecological cancer, because the symptoms, as we all are aware, are quite vague. So my name is Smrita. I am a consultant gynae oncologist at the University Hospitals of Coventry and Warwickshire, but I've got several hats with the Cancer Alliance. So I'm the chair of the expert gynecology group. I'm also the pathway lead for gynecological cancers, and I chair the PMB task and finish group as well, with the latest guidance. Kerry, I don't think has joined us, but she's my senior project manager, who's been a great help in helping us do this pathway, along with Sonia Ashraf, who's a GP by trade and is the deputy medical chair of the Cancer Alliance as well. So I think I'm very fortunate to work with a non-clinical senior management type of person and a clinical primary care person as well. So today, what I will quickly go through is, you know, what are the common gynecological cancers that you will see in primary care? What symptoms should probably raise suspicion of gynecological cancer, although they may not be quite obvious gynecological symptoms? What do you do if they have these symptoms? And then I will talk about so those of you who work with the ICB and have attended some talks before, we have introduced some new cancer referral forms. So what you would have called as a 2-week wait, we no longer call it 2-week wait, we call it urgent suspected cancer. Just to make things easier for you to tick as you go along, so that you are clear about what you're referring with, and secondary care who receives these referrals also know what you're referring with. And the reason this is important is because with as you know, primary care is inundated, secondary care is inundated, but what we have done is based on which pathway the patient is referred on, we triage to an appropriate clinic. And unfortunately, in secondary care, everybody's getting so super specialized that somebody who does, say, ovarian, screening, unfortunately may not be able to do an outpatient hysteroscopy. We've kind of gone backwards in that way, but that's how things are going. And then I'll talk a lot about the new guidance about unscheduled bleeding on HRT. So the first thing that you will see in primary care is ovarian cancer. And this is just what the NG12 guidance tells us from the NICE guidelines for management of gynecological cancers in primary care. Ovarian cancer is rare. We're very fortunate that it's rare on the grand scale of things. And we know that from all the evidence we've got is every GP will probably see one case of ovarian cancer every 5 years. And yet ovarian cancer is the one that kills women very, very quickly if it's not recognized, diagnosed, and treated quite soon. Most women are diagnosed with stage 3 and stage 4. And the drive now is, can we try and diagnose them early? So the standard pattern that we have until now, and we are getting better at this because everybody is getting more educated about it. The standard pattern is, on average, a woman sees her GP with vague gastrointestinal symptoms at least about 4 or 5 times before somebody thinks about doing a CA-125 and thinks whether she may have ovarian cancer. Now, this is the link I have over here. I will run it at the end if there is time. This is a really, really fantastic video for primary care produced by Sonia Ashraf, who, like I said, is a GP, and Janosch Baliga, my consultant gynae oncology colleague at City and Sandwell. And it's about how to recognize possibility of ovarian cancer in somebody attending with those symptoms. It's a pretty good video. And like I said, if we've got time at the end, I'll just put that video on and you can watch it whilst you're waiting for the next speaker. But if not, I'm very happy to send the slides through to everybody and you can watch it in your own time. What I've put here is the set of symptoms mentioned in the NICE guidance, which I think we're all more or less familiar with. So, where you examine the woman and find a ascites or a pelvic mass, which is not obviously uterine fibroids. And I appreciate in primary care, most GPs probably will struggle to know what is a fibroid and what is a large ovarian mass, because when they're both big, it's quite difficult. You feel something coming from the pelvis. So you can err on the side of caution. Persistent abdominal distension, women will often, and this is quite a common symptom, they feel a bit bloated, they feel early satiety or may have lost appetite, they may have pain, urinary urgency or frequency, unexplained weight loss, fatigue, change in bowel habit. So as you can see, pretty vague symptoms. And the other thing is, you investigate them, you do a CA-125, you may do an ultrasound scan and everything's normal. Please be aware that these women may have baby in the early stages of developing ovarian cancer, or you examine them, do a CA-125 and don't think this is ovarian cancer. If symptoms are persistent, think of ovarian cancer. Like I said, we know that on average, a woman with ovarian cancer will see her GP between 4 to 6 times before ovarian cancer is diagnosed. So what do you do if you suspect ovarian cancer? Well, the first thing is NICE guidance. And I'll talk about that in the next line that I've got. NICE guidance talks about women over 50. So it ignores the fact that women under 50 can get ovarian cancer, especially if they've got a family history with, the various genetic mutations that are coming up just now. We're becoming more and more aware of this. We're becoming more and more aware of younger women getting ovarian cancer. So the NICE guidance is quite old. It is being updated, but the current NICE guidance is the old version, and I think it's from 2019 or 2020, talks about women with all those symptoms over the age of 50. And we are advising that you ignore the age and just go with the symptoms in the first instance. There is a little caveat in there, and I'll come to that. So if you have somebody with these symptoms, please think ovarian cancer, irrespective of age. Examine them, take a family history, especially if they've got a family history of breast, bowel, ovarian cancer in the family. Think of the BRCA mutation and do a CA-125. If you can request a pelvic ultrasound scan urgently in the community, then you can do that. I'm afraid I'm not familiar with your region. So I don't know whether GPs in your region have access to ultrasound scans. In Coventry and Warwickshire, they do, but they don't have access to suspect. So within 2 weeks, their scans will take a bit longer, up to 6 weeks. So if you're thinking of cancer and the CA125 is elevated, please refer. If the CA125 is not elevated, then you can wait for 6 weeks for an ultrasound scan if she still has symptoms and you're suspicious. But also please think of a FIT test. Again, this is something that I think is gets forgotten pretty quickly in younger women. Older women, I think we're pretty good. But in younger women, if they've got all these symptoms, please also think of bowel cancer and do a FIT test. I don't know if you guys are aware, but FIT test can't be done in secondary care, which is really annoying because I can see a woman who's been referred on the ovarian cancer pathway. I do everything and I think she doesn't have ovarian cancer, but I want to do a FIT test. Secondary care is not allowed to do FIT testing. It's only commissioned for primary care. So I then have to write to the GP to say, can you please do a FIT test? And sometimes I get very annoyed replies. But if you get that from secondary care, that's why we cannot in secondary care do a FIT test. Now,
sorry to interrupt. Yeah. There's somebody saying that they can't see the slides. Now I can see them. Is there anyone else that's affecting? I think it's Dr. Holden, you can't see them.
Can everybody else see them? Is it just one person? Or I could unshare and share again.
I think there's a few people who can't see them actually.
Let me stop sharing. That's odd. I'm not a techie person, so apart from unsharing and sharing, like kicking the computer, I don't know what else to do.
There's quite a few people now coming up saying that they can't see
them. So I've stopped sharing, is that right?
Yeah, you've stopped sharing at the moment.
Let me share again. The other thing is maybe if I don't put it on a slideshow, can everybody see that? It's not on a slideshow.
Can the people who couldn't see it before, can you see it now? Yes, there's definitely
Shall I just continue on this without going on to slideshow? Maybe something happens when I go on a slideshow.
It's funny, that happened to our last speaker as well. So it may be best to stay on that one and do it manually. That would be better, I think. Yeah, I think it's fixed it for everyone.
Okay, you should all see a slide that says common gynae cancers.
Yes, there's lots of yeses and thumbs up in the chat. So that's
excellent.
Perfect.
Excellent. Sorry, guys. When I'm doing the slide presentation, I can't see any of you. So
no, I know.
I apologize.
Because I could see it. I didn't realize there was a problem.
Which is odd. Okay. So what was I talking about?
You were saying about not being able to do a FIT test in.
Thank you. Thanks. See this is what I mean. Okay, so yes, if you've got somebody with all these symptoms, please also think of a FIT test along with the CA125. So remember how I talked about the 50-year cutoff that NICE is talking of, and that makes us wonder, well, women under 50 also get cancers. However, the CA125 cutoff is not really a good one for the ones who are not menopausal, because we know that women with various conditions that are related to perimenopause and premenopause can also put CA125 up. CA125 is not a diagnostic test. So we get a lot of young girls with all these symptoms who have severe endometriosis. And when you do a CA125, of course, it's going to be up. And when you do an ultrasound scan, of course, they are going to have things wrong with them, and they will have symptoms that are in keeping with endometriosis. Now, currently, we can't really just change that, but there is a very good paper that has looked at CA125s, and it's a large cohort of women. And they've then done an age-wise distribution of the CA125. And they've found that in premenopausal women, a CA125 cutoff of about 75, 76 is a really good one to determine who needs to be referred on the cancer pathway and not. So the BSOL ICB within, so the West Midlands has 6 ICBs. BSOL ICB actually has agreed, so primary care have agreed to pilot this. So, but they have access to urgent 6-week scans in the community. So they have allocated slots, I think, in their secondary care scan clinics for these women. And we are piloting this with the hope that we can replicate the data in real time prospectively from that paper that collected the retrospective data, whereby premenopausal women who have all these symptoms and have a CA125 of 70 or less don't get referred on a suspected cancer pathway, but get referred for an ultrasound scan within 6 weeks. So they will have an ultrasound scan within 6 weeks. And then based on that ultrasound scan, management will be decided on in secondary care or primary care as is relevant. When you request your ultrasound scans going forward, I'm hoping that as your sonographers, primary and secondary care sonographers are getting trained, if they see an ovarian mass on ultrasound scan, they have been asked to do a risk stratification scoring, which is a lot better than you may have heard us talk about the risk of malignancy index. Now, the risk of malignancy index is what has traditionally been used to look to decide the suspicion of ovarian cancer, whereby you score them for either 1 or 3 based on the menopausal status. So if they're menopausal, it's a score of 3. If they're not menopausal, it's a score of 1. Ultrasound scoring goes from 1 to 3 based on how many risk factors they see in that ultrasound scan on the ovarian mass. And then it's multiplied by the level of CA125. And if the risk of malignancy index is more than 250, as per the Royal College of Obstetricians and Gynecologists, there is a higher suspicion of cancer. Now, that is not a good scoring system. It's really good because it's a basic system, and for the lack of anything else, it's good. But in developed countries, we should be able to score it a bit better. And this reduces these women feeling paranoid that they have cancer, but also avoids us from offering them unnecessary surgery, especially if they're premenopausal. So we offer, sonographers are being trained to offer the risk scoring, and you will hear these IOTA is 1, ORAD scoring is 1, and that's on ultrasound scan and MRI scans. And basically, this scoring helps you determine whether it's benign or malignant. So IOTA scoring, for example, the sonographer will look at various features on the scan and give it a B feature. A B is a benign feature, or an M feature, which is a malignant feature. So based on that, you can actually say, actually, if the patient has got an M feature, that's not good. I'm going to put her on the scan, the urgent suspected cancer pathway. There is a category that is intermediate, which obviously you will need to refer on a cancer pathway, and secondary care can then decide whether they want to do an MRI to facilitate risk stratification a bit better. And these MRIs will need contrast given to them as well. So that's about ovarian cancer. I keep going on mute. I don't know why. Right. So this is the new suspected cancer form, or the 2-week wait form for cancers that are not endometrial. And the reason the Alliance has done this, we had a big consultation. And like I said, I don't know, a lot of you may have been involved in that consultation via the ICB, is to differentiate between the uterine pathway and the non-uterine pathway.
Sorry, yeah? I don't think the slide has moved. I think it should have moved on, and it's stuck on the ovarian cancer one.
Now?
It's on ovarian at the moment.
Oh God. I'm going to unshare and share again. Okay, what can you see now?
I think that's still the same ovarian one, I'm afraid.
Doesn't say urgent suspected gynecological cancer referral form.
No, sorry.
Oh my goodness. Right. What can you see now?
It's not changed.
Is anybody there technically useful to me who can advise me what to do? I've unshared and shared.
Yeah, I mean,
leave it on that screen now, but just move it on manually. We can see that.
Right, what can you see now?
We can see the cancer referral form now.
Oh, thank goodness for that. Sorry, I've not had this problem before, so I don't know what I'm doing. I'm a very good surgeon, I'll assure you.
I think the previous speaker did. I think it's something Teams has done to itself today. Don't worry.
Okay, so yeah, like I said, we've introduced this cancer forms, and when I say we've introduced it, this is not something that is currently we're saying you have to use it. What we've said to the ICBs is obviously every ICB is slightly different in terms of its individual population, the way its facilities are in primary care and secondary care. So these are proposed models. I think there are some ICBs who've chosen to combine the two forms, but that just makes them really lengthy. So some ICB GPs have said, we don't want these lengthy forms, we just want two separate forms. What I've put over there is the non-uterine cancer form. And what's changed in that, apart from obviously we're asking for a bit more information that you may have not seen. So for example, we're asking if the patient is aware they have a cancer and a little more information in terms of is there an interpreter required or not, things like that, that just little prompts for the referring person to tell us to make our life a little bit easier and for the patient, because obviously if the patient requires an interpreter, we can't do a virtual consultation, we have to do it face to face. So little things like that. So this category here is about ovarian cancer, and basically it is just a yes, no tick box for all those nice criteria that I've discussed in the previous slide. And it is literally a tick box. So it's a guide to you to say, does this patient fit the box of ovarian cancer? When secondary care gets it, we've got that. You're also then telling us if the risk stratification scoring is available. And if it's available, obviously that's quite useful along with the size of the cyst. Now, the reason we've asked for size of the cyst is current evidence is that if the woman has a unilocular cyst and it is 3 centimeters or less, it's a physiological cyst and we do not need any further follow-up. Now, this is a little different from the outdated college guidelines, the Royal College of Obstetricians and Gynecologists, which talks about cysts of 1 centimeter. Everybody has cysts of 1 centimeter because our scans are getting more and more, they're getting better at recognizing pathology. Our ultrasonographers are getting better. So the current guidance is 3 centimeters and less, unilocular with no risk features. They don't need any further follow-up at all. And these women are normally picked up incidentally when you do a scan for, say, postmenopausal bleeding. We're also asking for a CA-125 blood test. It's a prompt for you to do a CA-125. And I think now EMIS is probably something that Coventry and Warwickshire use, but I'm sure all of you have some kind of electronic system. And I'm told that if this form talks to that, which is easy to do, then it could just be dragged from one system into another. Similarly, if you think the woman has got ovarian cancer, then we do ask for a Usenis and EGFR if you've done them. And the reason for that is for CT scan or an MRI scan, we need to give contrast. And if they've had bloods done and we don't have access to that, then they're just having unnecessary bloods again. So we can do imaging with contrast. So if you've got that, we're asking for that. So these are just prompts for the referring person to put things in. And then obviously the next 3 are just bog standard: cervical, vulval cancers, vaginal cancers, which, you know, once you've done an examination, you know if there's an abnormality there or not. With the cervical cancer, we're asking for history of cervical. Hello?
Oh, with the nice warm hands.
Sorry, was that somebody asking a question or?
I think we are still on the form. Is that correct?
Yes, we are still on the form.
Okay.
So the cervical cancer bit is on the right side of the form. So we're asking for just a little bit more information about the cervical smear test, because as you're aware, now cytology is centralized in the cytology laboratory in Wolverhampton, which means secondary care no longer gets a smear result that the GP has performed. And we have no way of accessing that. So it's useful if you tell us when the patient's last smear was, because if she needs an opportunist. Hello?
I think that's somebody who's unmuted.
Okay, fine. Some some secondary care colleagues and wanted to put genital swabs and urine samples for STI. And I think that's more to do with if somebody's been referred with postcoital bleeding or intermenstrual bleeding with a normal cervix. Now, in the little yellow bit here, we have said that this is actually not an indication for a 2-week wait referral. And there is a separate guidance for girls with postcoital bleeding that should about management of that, which usually is do the STI swabs and put them on some form of oral progesterone to regularize their period. And also we can give them vaginal acidity enhancers like Relactogel, Balance Active, etc., because that is what helps make ectopy better. Because most ectopy is because of the vaginal acidity becoming more alkaline. So that's, and then at the end, we've asked for a few things that help. Please indicate whether a patient has had a hysterectomy. Now, for most people, you think, oh, do you really need to put that? Answer is yes. The amount of times we have received referrals for postmenopausal bleeding, and the woman comes and says, I've actually had a hysterectomy. Now, why is that important? And that's important because this woman has been triaged to a clinic that has got ultrasound available, which is a waste of a slot, because a woman who's had a hysterectomy shouldn't be having a transvaginal ultrasound scan for postmenopausal bleeding. She needs examination, but doesn't need an ultrasound scan. So if she's triaged to an ultrasound scan appointment, she's taking that appointment away from somebody who should be triaged to an ultrasound scan appointment. So yeah, we asked these questions. Like I said, most of them are pretty straightforward. They're probably just gentle cues to say, please put this in. Body mass index, and we have all agreed that patients should be having a gynecological examination. Now, the discussion for this was that sometimes it's difficult to get a chaperone for an intimate examination. So I think the agreement now with primary and secondary care stakeholders, and again, this is for you to discuss within your ICB, nothing's written in stone here, is you can still put the request in and say that if she is not going to be examined in secondary care for maybe, postmenopausal bleeding where the scan is normal, then you will arrange an examination within 2 weeks. So that is also acceptable, but that is something that, you will need to discuss with the new ICB. And we have developed leaflets for transvaginal scans and hysteroscopies and postmenopausal bleeding, which, we have asked if you would want to hand them to your patients to make things easier, because a lot of women, especially if they've had things like sexual abuse, which recently there was a survey done where apparently 1 in 10 women have had some kind of unwanted sexual encounter in the past. So for these women to turn up and suddenly be told they're having, a transvaginal scan, etc., is pretty traumatic. So we say, well, for them to get prepared for it, at least if they have a leaflet to say, if you've been referred for, say, postmenopausal bleeding, this is what you may be offered. It's actually quite helpful. Has that moved now to the next slide?
Yes, we're on endometrial cancer.
Yes,
is that correct? Yeah.
So that's the ovarian cancer and the non-uterine cancer bit out of the way. The next section in NG12 is endometrial cancer. And this now talks about women. So the general consensus is all postmenopausal bleeding should be referred as suspected cancer as per NG12. However, what everybody forgets is NG12 actually specifies an age of 55 and over, or age of 55 and under who have had postmenopausal bleeding. It is not perimenopausal bleeding. NICE guidance is again pretty outdated. It does not cover HRT at all. And from the time when this NICE guidance was published to currently, we know what a rapid increase we have had in prescriptions of hormone replacement therapy. The other thing to remember is symptoms of hematuria. Occasionally, we have patients that arrive with advanced endometrial cancers in our clinics. And when we look back on it, a year ago, they may have had presentation with hematuria, but they went down the urologist route. Urologist did a cystoscopy, said everything was normal, did a renal ultrasound scan, said it was normal, discharged her back. She's been bleeding since, thinking, I've got hematuria. Well, what she had actually was abnormal vaginal bleeding because she had endometrial cancer. So if you've got a woman in that age group who thinks she's got hematuria, please do think of postmenopausal bleeding as well. These women also need a genital examination because postmenopausal bleeding doesn't mean endometrial cancer. It means cancer anywhere in the female genital tract. So although a pelvic ultrasound scan is done for uterine cancer, pelvic ultrasound scan does not pick up abnormalities of the vulva, vagina, and cervix. I've had 2 patients, right, in the last kind of 6 months where woman got referred with postmenopausal bleeding. She had an ultrasound scan and my trainee didn't do an examination. They just didn't think of it. And one patient had a vulval cancer and one patient had a cervical cancer. So I say this to everybody. Postmenopausal bleeding does not mean uterine cancer. You cannot diagnose postmenopausal bleeding causes on ultrasound scan alone. It has to be an examination and an ultrasound scan. Obviously, think of cervical smear history, because if that's abnormal, you are thinking of cervical cancer. And please do ask for vulval symptoms in terms of itching and symptoms of lichen sclerosis, because that could also be a cause of bleeding, and our endometrium may be perfectly normal. Has my slide moved?
Yes, well, management of unscheduled bleeding.
Yeah, so this is, I don't know how many of you have seen this. This is all the new furore. And British Menopause Society published this guidance in March or April this last year, no, 2024. And basically, it is about a 90 to 100 page document, and it's been published with, there are representations from, secondary care, primary care, sonographers, various professors of academic interest, and a lot of people from primary and secondary care who have interest in hormone replacement therapy, which, as we all know, is really, really complex. Now, the purpose of this guidance was that we have so many women, HRT prescriptions have increased at least 4-fold since post-COVID, because we've had the Davina McCall effect, with all of her talking about HRT. We've also got private clinics running within the West Midlands that, prescribe a lot of HRT and are known for their prescriptions of HRT. So we do get a lot of women in the Midlands who are on HRT. Some of them are on extremely high doses of HRT, and therefore it's quite important that we know about HRT and the right dosage. But the British Menopause Society guidance produced this because all these women were getting unscheduled bleeding, and they were then sitting on this suspected cancer pathway. Now, the problem with that is the likelihood of these women having cancer is extremely low. It's about 2%. So it's even less than, the NG12 cutoff, which I think is, if you think it's a 3% risk of cancer, we should be able to pick up 3%, I think, of cancers from referrals. Most of these women probably just need HRT modification because they are not on the correct doses of HRT, i.e. they're not on the correct dose of progesterone for the extremely high doses of estrogen they may be taking. And therefore, this guidance kind of clarifies that a little bit. Unfortunately, or fortunately for patients, but unfortunately, this guidance puts in a lot of responsibility, let me say, on primary care in managing HRT. And in the West Midlands, we have recognized that this is probably not feasible right now. However, we also recognize that we have a lot of primary care colleagues with extended roles who probably know more about HRT than I do as a gynae oncologist. And therefore, it's using the right resources within the right time frame in that region so that we don't put these women through a suspected cancer pathway. At the same time, we manage them appropriately, and we then release the spaces in the cancer pathway for women who actually may have cancer, and these women don't sit there clogging up the system. Therefore, perhaps you won't be able to see a cervical, vulval, or ovarian cancer lady in the same time period. Now, the next flow chart is what is published by the British Menopause Society guidance. We have simplified it a little bit for the West Midlands, but this is, so please don't freak out. I'm going to put that chart up. So I'm going to read up here from the top. So basically, and this is only for unscheduled bleeding on HRT. Okay, so any bleeding that is menopausal, and menopause is more than 12 months of amenorrhea, who are not on HRT is still a suspected cancer referral. There are also women who are a suspected cancer referral with things like unscheduled and abnormal bleeding on, say, tamoxifen. But there is a subgroup of women on HRT with unscheduled bleeding who also fit the cancer pathway. And that's where the risk stratification becomes quite important. So it says, basically, when a woman attends primary care with unscheduled bleeding on HRT, primary care will assess cancer risk factors and bleeding pattern, which I'm sure you all do. It identifies the HRT regime, duration, and compliance, offers examination, and offers investigation if indicated, such as cervical screening, genital swabs. I think 1, 3, and 4, you're probably all GPs are going to be happy with. 2, I think you would be happy with identifying it, but not all primary care colleagues, I'm sure, will be comfortable adjusting it, because there are, the first couple of prescriptions are probably quite easy. I have a lot of secondary care colleagues that would probably struggle with that as well. So what they've done is they've risk stratified, and at the bottom here, you've got some things that are called major risk factors. So if you have one major risk factor, and then they've got what are called as minor risk factors. So 1 major or 3 minor risk factors, they are suspected cancer. So they go down the suspected cancer route. You don't need to worry about them because they go down the suspected cancer route. Secondary care will deal with them right like they are dealing with them just now. And if their investigations are normal, then they'll come back to you with advice about monitoring and optimizing HRT. Whereas if we pick up endometrial cancer or hyperplasia, we will deal with it. It's this group that doesn't fit into the suspected cancer pathway. And to give you approximate kind of numbers, we recently did an audit from last year when we were following the old guidance where all women with postmenopausal bleeding, whether they were on HRT or not, were being referred. And by applying these risk criteria, we reduced the number of cancer referrals by 40%, but there were no increased numbers of cancers detected in these women. So criteria, 40% of women will probably not have the stress of thinking they have endometrial cancer. So if they don't have 1 major or 3 minor risk factors, they go down this route. And then you need to identify a few more risk factors, which is, do they have persistent bleeding, or is it just a one-off bleeding? Is it postcoital bleeding that's vaginal atrophy? Do they have 2 minor risk factors or less? And have they had bleeding since, more than 6 months of HRT or more than 3 months from a change of preparation? Once you've asked these questions, you will again get a yes and no pathway. And if you get a yes pathway, they should have an ultrasound scan within 6 weeks. That's what the British Menopause Society guidance says. Now, with the various meetings we've had with stakeholders, we've agreed to do 4 to 6 weeks. Again, this is something to be discussed individually in the ICBs. And who will provide these scans, whether it's sonographers in the community who are trained to do these scans, looking at endometrial thickness, or is it sonographers in secondary care where you've got direct access to it? So the important thing is direct access to an ultrasound scan within 6 weeks. And that has to be a guarantee from whoever is providing that ultrasound scan, without which primary care absolutely cannot agree to this pathway. And obviously, if they don't have any of those risk factors, we say optimize HRT. Now, again, British Menopause Society says optimize HRT for 6 months. In the West Midlands Cancer Alliance, because of the discomfort that people feel waiting for 6 months, we've agreed to say 3 months of optimizing HRT and review. And if there is persistent bleeding, then we are happy to accept them on this pathway again. So it's a compromise, really, because we understand it's a new pathway. So we've kind of said, well, maybe 6 months is a bit too much when a woman is bleeding all the time. So 3 months may be, something to review them at. And at that point, would you add more progesterone or would you refer? That's something that you might need to discuss within your ICB, and or maybe get a secondary care clinician to be on direct access for advice and guidance. Coming to my next slide. So this is the pathway proposed by the British Menopause Society. Based on this and various meetings within the Alliance over the last 12 to 14 months, we produced 2 models of delivery. And we said to all the ICBs, please go and discuss this with your primary and secondary care colleagues to see which model you prefer. So model 1 was where all primary care GPs are going to do what is proposed by the British Menopause Society pathway, which is all primary care GPs are really good at modifying HRT, which, as we all know, is probably not true. But we know that we have a lot of primary care colleagues who are experts in HRT with extended roles that are doing this day in and day out all the time. And therefore, the model that's chosen by all the 6 ICBs, including yours, is model 2. And model 2 basically is the primary care GP does the top bit on that pathway, which is examine, take a history, and risk stratify into, is this cancer or is this not cancer? That's it. So is this cancer means, do they have 1 major and 3 minor risk factors, or do they not? If it is cancer, they put it on a cancer pathway. If it is not cancer, you then refer to the GP with extended role. And again, this is for the ICBs to point out who. There is money within the alliance. It's non-recurrent funding, but it helps develop this pathway and suggest what a pilot should look like. Then your GP with extended role will look at the information provided and risk stratify based on the major and minor risk factors when it gets a bit more complicated, because it's looking at the nitty-gritties of the progesterone and estrogen prescribed, and they will then be able to modify the HRT. They can request the 6-week ultrasound scan. The ultrasound scan we have proposed will get done wherever, and a sonographer who's reasonably experienced, it is within their scope of practice to call it a normal or an abnormal scan. A sonographer will never be able to tell you what to do, but it is within their scope of practice based on a set of guidelines and accepted, and this is agreed by the sonographers. If it's a normal scan, it goes back to the GP to say, if she's not examined, please do an examination and modify HRT. If the scan is abnormal, which is anything, even if they've got maybe an ovarian cyst, a sonographer will say this is not normal, and therefore it automatically becomes a consultant upgrade until the consultant reviews the scan and decides what the management plan is, which may well be discharged to community or not. I know there are some ICBs. So for example, in Worcester, all GPs are quite happy to monitor benign ovarian cysts. In Coventry and Warwickshire, they are not. So again, you need to decide within your ICB what it is that you're comfortable with, and therefore you need to develop this pathway to yourself.
Can I just check that we're on the right slide? Oh, we were on proposed model 2, and then now
so
we're
that's
on
the model that you guys have accepted. All the 6 ICBs have said that's what they want to do.
Okay, and there is a question about where we'll get the pathways, but we will put
I'll
all
take
the
them
slides.
at the end. Yeah. So this form is purely for endometrial cancer. And as you can see, it looks really complex. And the reason it looks complex is we've tried to simplify it by putting the risk stratification within this form as well. Additionally, what we have done is put in an extra group, which is a high risk. And I think most GPs struggle with it because this is not a menopausal group. So menopause is more than 12 months of amenorrhea. We have got 2 categories that always cause confusion. One is this one here, where it's a perimenopausal woman who is 45 years or more with abnormal bleeding. And this is a high risk group if they have one of these risk factors, which is if they have a BMI of 40 or more, that's a risk factor. They come under a suspected cancer pathway, even if they are not menopausal, or they have history of Lynch or Cowden syndrome, or they have 3 of these 4 criteria, which is a BMI of 30 to 39, polycystic ovaries, diabetes, or they're nulliparous. Now, this is evidence-based, whatever evidence we have. So we've put that extra criteria in there, which is not currently on any of the suspected cancer forms. And I do know that this is the bit that often causes worry in primary care, because they're at a high risk of cancer, but when you look at the form, nowhere in the form can you tick the criteria that you think it's high risk. The other one is asymptomatic women, where they maybe have a CT scan for, say, hematuria, or I don't know, you go with abdominal pain, you go through that CT scanner that is in A&E, and they have a thickened endometrium on CT scans. Now, CT scans are not good at endometrial thickness, and therefore they need to have a transvaginal pelvic ultrasound scan. But sometimes these will be asymptomatic women, so they have had no bleeding whatsoever. Should you investigate these women? Well, again, we've put those risk factors in there. If they are, and this is based on the British Menopause Society guidance, if they're not on HRT, an endometrial thickness of 10 millimeters or more should be investigated with a hysteroscopy. However, if they are on HRT, then they have to follow the major and minor risk stratification, same as for women who are symptomatic with unscheduled bleeding. Then you've obviously got the criteria for, after modification of HRT for 3 attempts, etc. And the rest of it is exactly the same as you have on the other form. So you can see why some ICBs, primary care, wants to combine the 2 forms. It's just that it becomes 4 pages long rather than each form being 2 pages long. But the information will be exactly the same. Now, this slide is the one that I print this and I have it in my clinic when I do a PMB clinic, because this gives me the major and minor risk factors. And I just tick these as I go along. I ask the history and I tick whatever. And I know that if she's got 1 major risk factor or 3 minor risk factors, I'm worried about her. And then I look at the ultrasound scan and I decide what to do, which usually is either a hysteroscopy, biopsy, Marina coil as relevant. If she doesn't have 1 major and 3 minor risk factors, does she have 2 minor risk factors, in which case she can have modification of HRT based on what is currently happening, whether she's already modified her HRT before referral, and you can afford to have the ultrasound scan within 6 weeks. And if it's less than one risk factor or less, then she can modify her HRT, get reviewed in 3 months, modify HRT again, provided it's not persistent bleeding. So basically, there is an ultrasound scan that we've put out from the Alliance, which is for primary care or the GPs with extended roles who are requesting these scans to tick these boxes. And basically, reason for referral is persistent bleeding for more than equal to 3 months, or it starts after 6 months of HRT, or it's more than 3 months after changing HRT. Again, the BMS guidance says 6 months. We've said 3 months because we want to make it acceptable as a compromise to everybody. At the bottom end here, we have put a little description, and a lot of primary care colleagues helped us do this because I think people were getting quite confused on, what's sequential, what's combined, what's unopposed, what's not opposed. So an out-of-date Marina is obviously that is unopposed estrogen. So if somebody's on estrogen and has an out-of-date Marina, then it's unopposed estrogen. Similarly, norethistrone or Provida for less than 10 days per month, or micronized progesterone for less than 12 days is inadequate estrogen. And I don't know how many of us use Tridestra. I have yet to see a woman who is on Tridestra, so I don't know how commonly that is used as a tricycling HRT. And at the bottom end, we've also attached something called seed dosage table, which is a really useful table. So I have that slide and I have this slide open in front of me on my PC when I see patients, because I can never remember which is what. And this is, again, quite a good slide to see whether somebody is on the correct dose of progesterone for the dose of estrogen. And it gives you various versions of the estrogen and what is, equal to each other. Obviously, up to standard dose is licensed. Anything that is moderate to high dose is unlicensed. And that's probably where we see the highest risk of unscheduled bleeding, because they are on unlicensed doses of estrogen with normal doses of progesterone. So sometimes you'll see somebody with 6 sprays of Lenzetto with only 100 milligram of micronized progesterone or 2.5 milligrams of medroxyprogesterone. Well, it's no surprise that they will bleed because you need adequate progesterone to support the high doses of estrogen they get. The guideline does not focus on testosterone, but we do know that testosterone works by getting converted to estrogen within the body. And therefore, if a woman is on high doses of estrogen and testosterone, then they will need higher doses of progesterone. So to summarize, just thinking of all the cancers, vulva has got HPV dependent and HPV independent cancers. You don't need to do anything apart from examine the vulva. And obviously, if there's a vulval abnormality, put her on the vulval pathway. And nobody will ever decline a 2-week wait referral if you say there's an abnormality on the vulva. Similarly, with cervix, if you examine and there's an abnormality and or she's got history of abnormal smears, nobody will decline this referral. However, if it is postcoital bleeding in a younger woman, then please follow the guidance that is provided with it in terms of doing swabs, managing progesterone, giving vaginal acidic enhancers, etc. And please think of cervical cancer at any age. I do some medical legal reporting. And in the last couple of months, I had a case sent to me. This lady was about, I think, in her 30s. and she had DNA'd a couple of smears because she had been bleeding, and therefore she was said to come back after, her bleeding stops to arrange a smear. So she didn't really have a smear for about 4 or 5 years. Previous smear have all been normal, but she DNA'd smears for 4 or 5 years. Just happens that she was a busy lady. She had various children, was bleeding all the time, and she didn't have smear tests, but she attended her GP quite regularly with bleeding. And she never had a genital examination. All she got was the contraceptive pill, the progesterone pill, progesterone tablets, etc. And she got a transvaginal ultrasound scan, but nobody examined her cervix. 4 years down the line, she had advanced cervical cancer. And that's always struck with me. I see these cases occasionally, and you think, if somebody had just done a speculum examination and looked at her cervix, knowing that she had not been able to have her smears, could we have picked this up sooner? So please think of cervical cancer at any age, old, young, whatever, and do an examination of the cervix. With uterus, I think I've talked enough of uterine cancer bleeding. So obviously, if they've got unscheduled bleeding on HRT, think of the risk factors that will risk stratify. Again, this is not something you're currently doing. We would encourage you to do this, but again, it is within your ICB to see how they're going to introduce this. And with the ovarian cancer, remember NICE guidelines. However, do remember FIT testing and beware of repeated attendances of women with vague GI symptoms. The next 2 slides I've put on is because the British Menopause Society has some really, really good tools for all clinicians who deal with menopause, HRT, etc. And these are just like 1-page, documents that you just go on the website and you click on it and you get it. And I would encourage everybody to look at it, now and again. It also gives you some guidance about some prescription of maybe stuff that we are not used to. For example, we probably have very few patients who don't like the utrogestan orally, and they can have utrogestan vaginally. There are patients who use testosterone. Ospemifene is something that is used for vulvovaginal atrophy in women who have estrogen-dependent cancers. So very often I get advice and guidance about, this woman has breast cancer. She has really bad vulvovaginal atrophy. Can I use vaginal estrogen? Yes, you can use vaginal estrogen in limited quantities, but if it is a prolonged thing, then you could try using ospemifene as well. And it's just a 1-page document about, it's a tablet that you take, and it just tells you a little bit about the drug, how to prescribe it, etc. So if you've got time, I would encourage you to go onto the British Menopause Society website and look up these things. I am going to stop there and take any questions. And if you want me to run the video, I can. But otherwise, again, that ovarian cancer video produced by the Midlands Cancer Alliance is just here. Thank you. Happy to take questions.
Just going through the chat, I think people were wanting copies of the pathways and things, but we will share that
remember
on the website. Yeah,
these pathways are not introduced because it's for your ICB to do that. So please don't start using them straight away.
No, I think it was just some of your slides have been extremely useful, especially with the progesterone doses and things. People just asking if they could.
Yeah, sure. I'll send it to, I think whoever sent me the link, I'll send that my slides over. I'm happy.
Send it to Louise. That's perfect. Thank you. I don't know if anyone else has got any questions. It's hard to see hands raising. So if anyone's got any questions, please unmic themselves and perhaps put their camera on and ask a question. That would be lovely. Just while we're waiting, I'm just wondering, is there any evidence that there are younger women getting ovarian cancer than there used to, a bit like younger people are getting bowel cancer? And I heard something that it was perhaps related to more use of IVF treatments in younger women that were getting more ovarian cancers, or is that a myth?
No, I think they're getting better at picking it up, I think. I've not really heard about the incidence of ovarian cancer going up. Incidence of endometrial cancer is going up because everybody's getting obese and what have you. But the incidence of ovarian cancer has more or less remained the same. But I think we're getting better at picking it up and therefore hopefully managing them a little bit earlier. But the UK is one of the worst countries in the world for our mortality and morbidity rates from ovarian cancer. One of the worst. And Midlands is one of the bad ones in the country. I think that's why the Cancer Alliance has produced these videos to increase education, really.
Yeah. There's lots of thank yous in the chat. I know you can't see it for such an informative session. Lindsay's got a question. Do you want to ask it in person, Lindsay?
So it says, as the marina license is extended to 8 years over 40, if a lady gets onset of irregular bleeding after not bleeding, should the marina be removed prior to the scan? My answer is probably no, if it's within the licensed usage. Now for HRT, the license is not for 8 years. For HRT, the license was 4 years and now it's 5 years. Actually, no, the license is still 4 years, but the British Menopause Society and the Faculty for Reproductive Health says that you can use the marina for 5 years with HRT. I wouldn't recommend removing the marina coil because a lot of times we can still see polyps and thickened endometrium. Occasionally, we might have to remove the marina prior to the scan, but I wouldn't say remove the marina for all referrals.
Oh, that's great. Thank you. It's just that I've had a few ladies recently who've come in, and the marina's around 5 years, but they had it inserted after the age of 40, and they've not bled since it was inserted, and then they've started bleeding at the age of 47, when in theory the marina should still be active. We've sent them for a scan, and the scan report is really vague, just saying
so the scan report will say endometrium not seen. Unless they're on HRT, that's not something you would want to worry about.
Okay, that answers my question. Thank you.
Any other questions out there?
No, this is a really good group.
Well
I would have been eaten alive by now in Coventry and Warwickshire.
No, we're well behaved in Staffordshire and Stoke. That was really, really good. It was packed with information. I think
you very much.
I was making some notes as we went along. The product you mentioned for treating ectropions. I've not prescribed that at all. Could you just how long do you give it for?
So it's over the counter. You can get, it's called Balance Active or Relacta Gel. So what they are is little sachets which replace vaginal acidity. It's like gel-like stuff. It just replaces the vaginal acidity. So it's really good for patients with, say, bacterial vaginosis as well, because all these things are related to reduced vaginal acidity, isn't it? Because if they use spermicides and things like that for contraception, then the vaginal acidity changes. So it can be used for any condition that changes vaginal acidity. Balance Active or Relacta Gel. There are 2 versions over the counter, and it comes in a little sachet, and they put it in the vagina at the end of a period for about 3 nights every month. And that's meant to replace the vaginal acidity, and the ectropion stops bleeding.
That's really helpful, because I'm sure that's that happens quite often. Those are queries we get, and I never know how long to say to use it for.
I can send the guidance I've got for Coventry and Warwickshire to Louise as well, if it's helpful.
I think that would be for a lot of us. That would be great.
Yeah, and the other one is obviously tamoxifen is the other one, because we get a lot of inquiries from the breast team, because they will routinely do a CT scan perhaps for women following up for breast cancer on tamoxifen, and the CT scan will highlight saying endometrial thickness is thickened. Women on tamoxifen should not be investigated for thickened endometrium unless they have abnormal bleeding. So, endometrium looks thickened when on tamoxifen, but it's not cancer. It's just subepithelial thickening, which is quite normal. So unless they have abnormal bleeding, we would not investigate women on tamoxifen with thickened endometrium.
Oh, that's a good insight as well. I didn't realise that either. So thank you for that. I think there's a couple of people who would like that guidance. If you could forward it to us, that'd be lovely. Thank you.
Thank you very much.
Thank you for your time this afternoon. Really, really good talk. Bye.
Thank you. Bye-bye.
And Louise, I think, do we know if our colleague, the medical examiner, has joined us now?
Yes, Sam's here. I can see that he's joined the session.
I couldn't see his name on the list. Sam,
hello.
Hi, are you, sorry to call on you to come earlier than planned, but we're running a little bit ahead of time for once. Are you happy to go ahead and share some of the sort of how it's been being a medical examiner for this year with us? Would that be okay?
Yeah, absolutely. Now I've got some slides just to flick through if I'm okay just to screen share or
Yeah,
that on
we've had some
shortly.
problems with screen sharing this afternoon, so we'll see how it goes.
Let's give it a go. Can you see that? Is that working okay?
Yes, we've decided that if you put it into slideshow, it doesn't always progress. So we'll perhaps see if you can move them on. Oh yeah, no, yours are moving on fine.
Brilliant. Okay.
Perfect, thank you.
Oh, that's great. Now, I've just been asked to come along just to give, I think, a bit of a brief update about how things are going for the medical examiner service, and I think just a bit of a Q&A, just opportunity for, anybody to ask any questions, raise issues. Hopefully there won't be too many. It's always a bit of a lion's den when it comes to the ME service, but I'm here, ready to listen and take on any questions you've got. So I'm sure I may well have spoken to quite a few of you on the call today before now, but my name's Sam. I'm the Senior Medical Examiner Officer for UHNM, so I'm based at the Royal Stoke and County Hospital sites, and we provide the medical examiner scrutiny service to the majority of GPs in the Staffordshire and Stoke-on-Trent area. The sort of south and easter parts of staffs are covered by Derby and Burton and Wolverhampton, so there might be GPs on this call. I'm not sure that fall within those areas, but we cover the north and the Stoke areas. So just to give a bit of a sort of brief current overview of how it's going. So obviously the death certification reforms went live on the 9th of September, as we're all, I'm sure, aware. Locally, as sort of in contrary to what we're hearing quite a bit of, we're actually doing very, very well, and when benchmarked against other services across not just our region but all of England and Wales, our service and our sort of system that we've got set up for the staffs in Stoke-on-Trent area, from a performance perspective, through partnership work in our service, the key stakeholders being registrars and coroners, but also from our referrers, our service users, as in GPs, hospices, etc. We are performing extremely well. Delays to family are families, sort of funeral arrangements are minimal. I really cannot stress enough how well and robust our processes are working. There are teething problems. It's a new system, but we can go through those. So current kind of situation, obviously the law will change 9th of September, meaning every death now is reported either to a coroner or scrutinised by a medical examiner before the family can register the death. So the medical examiner, or one of our medical examiners, who are all consultants or GPs, the senior doctors that have to countersign the medical certificate of cause of death. We did have a couple of questions recently where they were a bit concerning that there was some miscommunication, that I think some GPs thought that medical examiners weren't medical or weren't doctors, and that's absolutely wrong. To countersign the MCCD, the medical examiner has been sufficiently trained. They are GMC registered, they are senior clinicians. So every death certificate now gets countersigned by one of these specially trained medical examiners. They're based at either Royal Stoke or County Hospital sites. We office work, there's no kind of remote working for this service. It is quite kind of paper heavy still, hence it is an office-based role. As part of the process, all families are provided with an opportunity to ask questions, voice concerns about the death, raise any issues that they've got, and we will signpost them appropriately. The few and far between. We don't have a massive amount of concerns that are raised, but where we do have cases where families raise issues, we'll signpost appropriately. It's not the role of a medical examiner to investigate any issues or concerns. Obviously the coroner's service is there to investigate unnatural deaths or potentially unnatural deaths, but the medical examiner is not here to do that. We're here to highlight potential issues or trends, that kind of thing. We won't look into things as such. We'll just look to see, are there any obvious issues that we need to tell the coroner about? The process, which I find is always helpful at these kinds of training sessions, just to sort of give a bit of an overview of, in my words, best practice, how all service users should kind of be working, how, you know, if you're a GP or a hospice doctor, whoever, if you're a doctor that's issuing an MCCD and referring into the medical examiner service, this is kind of, you know, gold standard, best quality way it should be done, and is most effective for all involved, really, from an attending practitioner's perspective as the GP, but also from our perspective, it makes things much more efficient, and for the family, it benefits them too. So as always, still the GP determines whether or not they can give a cause of death, or, you know, if the death needs to be reported to the coroner. If a death is reportable to the coroner, it bypasses the ME system. There's no need to also notify the medical examiner service of a death that you've put through to the coroner's services. It's one or the other. We don't need both. If the death is not being reported to a coroner, every MCCD now needs to come through the medical examiner service. So as I'm sure most are familiar with now, we have a referral form as well as the MCCD that are submitted together. And that kind of moves on to the next step, really. That process can and should really sit with practice administration staff. There's no need really for the GP to be involved in the admin side at all. The GP just needs to determine the cause of death and, if possible, complete the MCCD. Ensure to do a bit of a quality check before passing that back to the administration staff. We do tend to find a lot of the problems that we come up against are having to bat things back because things haven't been filled in, or there's like a date missing or something like that. It's not us being sort of tedious and pernickety about things. The registration service, the registrars of births and deaths at the local authority, they physically will not accept a certificate that's not been completed in full, so we have to send them back. But it tends to be us now that does that, rather than the registrars as in years gone by. So the practice admin team, step 2, will send that MCCD, they'll scan it across to our referrals account. It's a shared nhs.net mailbox. It's all sent securely along with the referral form. That case will then be scrutinised by our medical examiner, so our process kind of then begins. The medical examiner will have an independent overview of the circumstances of the patient's death, the care that they've received leading to, you know, death, and also the cause of death that's been proposed. They'll have, you know, a look at it and make sure that it's proportionate. It looks, you know, along the right kind of lines, and it's in the same kind of view as to what the medical examiner's come up with from their own independent view. It's not to mean that, you know, the medical examiner's cause of death has to exactly match what the attending practitioner has put on the certificate. There will be changes. There are always differences of opinions. But what I would say is, if any, you know, referrer, a GP, or, you know, whoever is issued a certificate, receives a request to change a cause of death after you've already submitted a certificate to us, and if you don't agree with what's being proposed by the medical examiner, you are not being, you know, forced into changing that cause of death. It's a dialogue, it's a two-way conversation. You know, we have no power to force anybody to change a certificate. It is still ultimately the attending practitioner's certificate. You own that form. You know, you'll never be forced into changing anything at all. So our process kind of ends with a family conversation. We talk to them about what they need to do next. We've taken that burden away really from practices. We explain to the relatives, this is how now you go to register the death, and we pass the certificate on to the registrar. Main sort of themes, trends, issues, and whatnot that we've picked up so far, about sort of 4 months in now, 3 or 4 months in. With the certificates themselves, as I've already mentioned, we do tend to have to send things back quite a bit, just because boxes haven't been ticked, that kind of thing. It really is simple little bits. The best advice that I can always offer is that, because the process primarily sits with practice administration staff, if those individuals, those teams can be in the habit of, you know, completing a bit of a quality check, looking through that form word for word, line for line, before sending it across to us, you'll pick up on the mistakes at that point, and it saves a whole lot of time really for everybody that's involved. There's new sections on that form. The new medical certificate of cause of death, it changed with these new laws that were implemented on the 9th of September. There's new sections that have been added, such as the pregnancy status, NHS number, etc. The back of the form looks different, and it's the newer sections we are finding that tend to be, you know, forgotten about, or they've just not been filled in. They are self-explanatory in what they're asking. The form itself isn't misleading or, you know, confusing. It's just that they tend to be forgotten, and we're having to send those back. Spelling mistakes and abbreviations as well. Again, the registration service, the registrars, people who register the debts in the local authority, they are not allowed to accept certificates that have spelling mistakes anymore. Previously to the 9th of September, they could. They were allowed to transcribe onto the official death certificate, the official document that the family are given. They were able to type spelling mistakes if something had been spelled incorrectly on a certificate. Now they can't, so we're having to bat those back as well. But we're also finding this has kind of improved in recent weeks and months actually, but initially, and there are still the odd few referrals that we'll get through where a certificate isn't sent at the same time as a referral. So we just received the referral form, but no MCCD. And I've found from some practices that doctors are more comfortable to wait for some kind of confirmation that the medical examiner scrutinised the case before putting pen to paper. That's not necessary. Absolutely, there's no reason to wait for the medical examiner to look at the form, look at your referral and proposed cause of death before putting pen to paper. It can't be released to a registrar. It's not a legal document until the medical examiner has countersigned and added their signature. It can't be used for registration purposes. The body can't be buried or cremated. So there's no reason to not send us the certificate at the same time as a referral. The whole reason we're asking this is because if it comes through at the same time as the referral, if there's no problem with it, we can countersign, send it off to the registrar, done and dusted, family can proceed with their arrangements. If we don't have it and we're having to then email the practice and say, please can we now have the certificate, it's delaying things at, an extra day, 2 days, sometimes even a week, if somebody's gone on annual leave or sick or whatever. It's best practice that we get the certificate at the same time as the referral form. And same kind of common themes, trends really with referrals, just incomplete forms, missing information, but we've tried to keep it as simple as we possibly can. We're not asking for a whole load of information. The only thing I would mention at this point are for TPP, the System 1 practices. We don't have like a record viewer solution. For EMIS, we have an EPR viewer. We can access EMIS patient records. But for System 1, we can't. We've not been able to put any solution in place with the ICB for that. That's not something we've been able to kind of sort out locally. It's the ICB's, procuring and things like that. It's not something that we've been able to sort. So for the System 1 practices, we have to have like a bit of a synopsis, a bit of a story to explain how you've arrived at that cause of death. We don't need paragraphs and pages and pages and pages like the coroner's service, for example, because they can't see anything at all. They don't have a hospital records even. For the coroner, you really do need to give them a very detailed story as to why, this patient, what the circumstances are about that referral. For us, we don't need that, but what we do need is a bit of a short few sentences about how you've arrived at that cause of death, because we can't see your records with System 1. The last issue that I would raise at this point as well, just for awareness all around really, and I'll keep banging on about it, we're repeatedly, I would say, daily at the moment, having contact details supplied for the deceased in the next of kin boxes on referral forms, which is obviously very distressing for family members. A lot of the time, those mobiles belonging to the deceased have been switched off already, and they're not going to ring. But quite often there are occasions where we are ringing these contact numbers that we've been provided with, seemingly for perhaps the patient's son, daughter, whoever the next of kin is, for them to answer the phone quite taken aback, quite out of breath, really distressed, and they'll tell us that was their their loved one's mobile number or mobile phone. And it seems when we've raised this with referrers, it seems to be it's just a case of they've copied and pasted, or they've perhaps written the number in from the wrong box of a system, looking at it, and we're getting apologies and things, which is absolutely fine, but it's distress that we're getting from families. It's just something that we could ask for, really, of people to be mindful that we're getting the contact number for next of kin rather than the deceased themselves. That's just something to mention and keep in mind. Our contact details, I've only put these there just as a bit of a useful information for everybody. My direct contact details are always available, my email address and landline, for any kind of non-urgent queries, anything you want to raise with me, any issues that you've had about a referral or a case itself, or sort of training, if there's anything at all that I can help with. Come into the practice, talk to staff. If you need any assistance whatsoever, I'm here. I'm kind of like the operational manager for this service. We have a head of service who's Vicky, who's also available, but generally if you email me or ring my landline, I'll always be able to get back to you. Referrals, however, should always be sent directly to the generic nhs.net mailbox as above. If I'm perhaps on annual leave or can't access my emails for a morning or whatever, I have had a few referrals sent to me directly, which is unfortunate, because obviously it can't be processed until I've seen it. Whereas the shared mailbox, we have multiple members of staff. There is a duty rota. Somebody is constantly monitoring that account, and we work as quickly as we possibly can. So yeah, referrals always to the generic shared mailbox. Anything else, any assistance that you need, I'm there and available. And I did say it was short and sweet, but there we go. That's the end. It's just a bit of an update, and I think it's always helpful that I can come along and chat at any opportunity. So any questions anybody's got, really feel free to fire away.
There is a question in the chat, I think, actually, which is from Lindsay. I don't know, Lindsay, if you want to ask, and there's a couple of hands up as well.
I can just see I'm just opening the chat now. Sorry, the computer's going ever so slow. So from Lindsay then, so both GP notes and any hospital notes. As most nursing homes, patients are now seen by AMPs. Can you remind us of the guidance? Who can fill in the certificate and any time frames in which they should have seen the patient? Okay, good couple of questions there. So we were hoping that under the new legislation that there was going to be something written in so that a senior nurse practitioners, whoever, could issue death certificates, but unfortunately that hasn't happened. There's no legislation, there's no facility whatever for nursing staff to write death certificates. It always has to be somebody that's registered with the GMC, has a GMC number. It's got to be a doctor. Unfortunately, nurses can't. For those patients that are only seen by ANPs and haven't at all been seen by a doctor in a practice, or doctor in a hospital, wherever, if a doctor's physically never seen that patient, the advice currently still is refer to the coroner's office, because no attending practitioner is available. The new legislation has been written purposefully vague, as the wording that we've been given from kind of the regional and national medical examiner leads. There is supposed to be some provision whereby the definition of attending has changed, so that if somebody was perhaps involved in an MDT meeting or a practice meeting about patient care and a particular patient's circumstances were discussed and decisions were made during a meeting, and somebody was involved in decision making but has never physically laid eyes on that patient, whether in person or via video link, that doctor should be able to issue a death certificate as an attending practitioner. We haven't in this area started to sort of use that really, or allow those circumstances to come through. The law is far too vague. There's no real guidance around that as yet. It's something that's been raised at a national level, and we're waiting for the Department of Health and Social Care to release some kind of guidance or code that we can all follow to clearly define what is classed as an attending practitioner. Because for me, I'd feel uncomfortable for someone that was just sat in a meeting to then go ahead and issue a death certificate. For me, I can't grasp how that could be explained as having attended somebody. So we're not using that rule at the moment. That may change in the coming months, years, I don't know. As soon as we get any guidance whatsoever, I'll make sure to personally share that out as far and wide as I possibly can, but we'll also have the support from ICB comms team, etc. So we'll make sure we share all of that as soon as possible. In terms of timeframes, there isn't any. So the law changed from the 9th of September. There is no longer a last seen alive section of the MCCD. There isn't a time frame. As long as you have treated that patient at some point in their life, and you are able to state the cause of death to the best of your knowledge and belief, you've attended them in their last illness, you can issue that death certificate. You could well have seen, perhaps the example I tend to use is, say a chronically unwell child that was born, I don't know, 10, 15 years ago, and you attended them for that same illness that they've gone on to die from however many years later. You've attended them, you've seen them at some point, you know the cause of death, you're happy with that, there's no suspicious circumstances, you could issue the death certificate even if you've not seen them for 15 years. You may not feel comfortable to do so, and that is absolutely fine. There is no pressure for you to issue the death certificate, but if you feel able to do so, absolutely, by all means. There's no legal definition or time frame now.
You've got three.
That's lovely. That answers my question. Just to lead on from that, it's really that sometimes in our nursing homes, patients are discharged on a palliative pathway to a nursing home that's slightly out of area, and then they're attended by our nurse practitioner who goes to see them, and then unfortunately we don't quite get to see them before they die. So the nurse might come back and talk to us, and we'll issue palliative drugs and make sure the patient's comfortable and endeavour to go out and visit or do a video call that day, and something happens before we get a chance to do that. So would that then still be a coroner's referral? Because they've never seen
unfortunately, yeah. I mean, to avoid the laboursome task of having to put the case through the coroner's portal system, because I appreciate GPs have to do that. We use it the same for the hospital deaths. It's easier to report a death to the medical examiner service than the coroner, because ours is just an EMIS populated referral form. If you're aware that the patient's been discharged from Royal Stoke and County Hospital or County Hospital in the weeks or a month or whatever prior to their death, and they've been made palliative from that admission, and you think a hospital doctor's likely going to be able to give a cause of death, by all means send it to us first. We can coordinate and ask one of the doctors in the hospital, can they issue a death certificate? And if they are able to do so, we'd sort that out without having to involve the coroner whatsoever. So it saves you that time having to sit and use the coroner's portal system. But obviously for those cases where patients weren't actually discharged from Royal Stoke and County, the other, medical examiner services at other hospitals work all very, very differently. For us, however, it's, we're happy to take that pragmatic approach. The doctor's likely to be able to help in the hospital, make us aware, we'll contact them and see if they can help. And it probably doesn't need to involve the coroner at all. In instances, if the patient's not being discharged, if there hasn't been any kind of recent hospital attendance, there is now under the new laws, there's a provision for medical examiners to issue MCCDs only at the request of the senior coroner. So they can issue a new form called a coroner notification 1B, and that's sort of a request to the medical examiner from the coroner for the ME to issue an MCCD because it's seemingly a natural death. Palliative nurses might have been involved, but there's been no doctor in attendance. So those are quite regular now. We're having perhaps 1 or 2 a week of those kinds of cases. There's different options. I'd just say look at it on a kind of case-by-case basis.
And I think, Sam, you had your hand up first.
Great, thanks. Yeah, thanks, Samuel, for that great overview of the current services. I just got a quick question regarding, I wanted some clarity really about the two pathways. So we've got a coroner pathway and the medical examiner pathway. I had a case last week where I felt a patient, it was an unexpected death, fairly young, mid-50s, and I did a coroner portal referral because there was nothing leading up to it. It wasn't clear, and I was unhappy to issue. The coroner got back after a couple of days and said, well, we've looked at what you presented to us, and we feel happy with you writing this as a cause of death. So I looked at the case again and thought, okay, yeah, I feel that I could do that. So I did, and sent that notification to the coroner and thought that was all I needed to do. 2 or 3 days later, we had a call from the funeral directors and the relatives saying, where's the certificate? And it turned out that we should have sent that to the medical examiner, but we weren't aware of that. We thought there was 2 pathways. We didn't know we needed to let both know. So that caused a bit of distress for the family in terms of not having the note, and we feeling like we didn't really know what we were doing with this note. So can you just clarify what I did right or wrong, or what went wrong in that situation for me?
Yeah, absolutely. I mean, it sounds as though they've not sent the follow-up email. So what would have happened is, yes, absolutely, if you've reported the death to the coroner along the lines of, I don't know why the patient's died, you've done the right thing there. You don't need to involve the ME at all. If the coroner then, in agreement with a GP or attending doctor, comes up with a cause of death, and the GP or whoever agrees that seems okay, I'm happy to write, I would be happy to agree with that. The coroner would then issue this coroner notification 1, CN 1A form, and that is a sort of authorization for a GP or whoever to issue the MCCD. They email that back to the practice, and they would normally copy our office in as well to advise that a coroner has received a report of a death, but the coroner's deemed that there's no duty to investigate under section whatever of the Coroners and Justice Act. At that point, a doctor's then expected to issue the MCCD and forward it to the medical examiner service, even though the coroner's been involved, because there's no investigation as such. So a coroner's investigation is now only an inquest or a post-mortem. The fact that they've made preliminary inquiries isn't relevant. If an MCCD is to be issued because a cause of death's been agreed, it still has to come to the ME for countersigning, which I won't go into it too much because it'll raise too many, I think, questions and whatnot, but then obviously leads to the fact that the ME has to agree with that cause of death and countersign that certificate. So my advice would be only if you absolutely do agree with what's been proposed by the coroner's service and you feel, you know, you are happy to say, yes, that is the cause of death to the best of my knowledge and belief. Only say yes in those instances. Don't agree if if you just feel as though you've had confirmation that the coroner's looked at it and is satisfied that they don't want to do a post-mortem or an inquest, and if they've sort of proposed the cause of death. If it's not something that you would have picked yourself, if it's not something that perhaps you entirely agree with, don't agree to issue the MCCD, because the coroner will just take that as a doctor has agreed with the cause of death. My duty is no longer engaged. The doctor needs to issue the MCCD. So from what went wrong, essentially, it is just a case of the MCCD should have been issued. If the coroner's not doing an inquest or a post-mortem, the CN1A form would be issued, but they should have sent that to the practice, and it does set out in the email.
Just to make, we did get that, and I did do the death certificate, sent it to the coroner. But then we weren't aware that we needed to send it to the medical examiner as well. That's what I'm saying. That's the point.
Yeah, no. So the coroner doesn't receive MCCDs. They should have come back and just said thanks, but no, we don't need it. That's for the ME service. But it does say, I think, in the template from the coroner's service, I think it says, please issue the MCCD and liaise with the medical examiner about this. So I just use the analogy, if it's an MCCD, always to the ME, just send it to us and not the coroner's service.
Just to clarify, that is just the certificate we sent the ME. We don't have to fill in the whole form again.
No, because we've got the circumstances from the coroner then. If the death's been reported to the coroner and they issue this CN1A, they send it back to the GP, copy our office in, and I think they attach what they call a case information summary. Perfect for us, because that sets out exactly what you've typed into the coroner's portal system, so we can see, the circumstances. We don't need a referral form as well.
Great. Really appreciate that answer. Thanks a lot.
No worries at all.
And then I think it's
Can I ask something?
Sanders Crook. Well, we do have it. Somebody's already had their hand up, actually. So Lee Sanders Crook has been patiently waiting. Could we come to you afterwards, Ravi? Would that be okay?
Sure.
Thank you for the update, Samuel. I think you touched on it briefly, but just to clarify, in the circumstance where if I've issued a death certificate, sent it through, and the ME suggests changes that I may disagree with, did you say that basically if we've received the update from the ME and we say no, we don't agree, it just goes through?
If you don't agree with the changes that the ME is proposing, it should be, a dialogue. Like I say, I wouldn't sort of straight away, no, I don't agree with that. I'm not gonna respond or whatever. If it's a phone call, brilliant, you can have that conversation straight away. If you've just got an email, explaining a simple, what we would kind of class as a simple change, but if you still, don't agree with that, ask for a conversation. Either, feel free to phone us directly. There is always a medical examiner available on duty, or should be available on duty to talk to. And it's a straight, direct telephone number to us. There's no call centres or whatever in between. Or, respond to an email and say, I'm available at whatever time. Please, can you call me to discuss this further? If through dialogue and conversations, you still don't agree, you're not happy to issue that MCCD as the ME has proposed, that's absolutely fine. You're not being forced into it. It's your certificate. You don't have to sign a new one. Obviously, we've got to appreciate that there's families at the end of this.
So yeah, the circumstance was, I'd already discussed with the family. They were completely happy with the cause of death as discussed, issued the MCCD, which it was on 3 occasions rejected for arguably slightly pedantic reasons. And effectively, what ended up happening was it came back. It was then discussed with a different GP, because if I wasn't in all the time, and then they ended up in each case having another medical certificate done. So it ended up delaying by about a week what should have been quite straightforward certificates. And it was just interesting to note, is that something that should be happening routinely, or can we just say, actually, no, we're happy with the certificate?
Yeah, there's, like I've said, you're not being forced, and then no other doctor from the practice should be, feel pressure to have to change it to, I have to keep in mind the fact that yes, families are waiting for these forms. There's got to be an emphasis on let's work quickly, let's work effectively together to get it resolved. But if doctors within the practice are in agreement with one another that actually no, this is a perfectly acceptable certificate, we think this is the cause of death to the best of our knowledge and belief, you don't need to change it. If in the event that you've got a case where you feel this seems like a really pedantic change, like I said, I'd encourage dialogue conversation with the ME that's on duty, whoever's in the office to chat to about it. If you can't get a hold of anybody, feel free to call or email me directly. Or if this is a sort of, if you feel that this is kind of a recurring thing or it's becoming a bit of an annoyance, pass me the case details in an email. I'll look into them, and if genuinely there may well be learning opportunities for our team, if there's something that we can stop doing because actually it's not necessary, we will take that up. At the end of the day, we're all learning. It's a new system. We will educate where necessary, but there may well be underlying reasons behind why we've had to suggest changes. It could be mortality statistics, it could be from a coding perspective things may well be structured slightly better, but again that's where kind of the two-way communication comes into it really. But I'd encourage, if there's any cases like that, anybody is welcome to email me the case specifics and we'll look into it and feedback. Actually, is there anything that we've raised with the ME that was involved, or was this, in our view, actually a fair request?
That's fine. Thank you.
No problem. Any other hands?
Yeah, can I just ask, suppose in the case of a sudden death, when we refer to the coroner, they may suggest a cause of death for us to issue, which we are not happy with. And then what will happen?
If you've reported a death to the coroner, they come back and suggest a cause of death that you disagree with, you don't need to agree. You can go back and explain exactly that. No, I don't agree with that cause of death. There's no pressure from any angle. It simply requests. Obviously, the coroner should only sanction post-mortems where they're absolutely necessary, and clearly they will attempt to establish a most probable cause of death. Coroner works on balance of probability. Obviously, in GMC land, we work on best of knowledge and belief. So slight, differences there. But if you don't agree with what's being proposed, don't say yes to it. Go back, stand your ground, say no, these are my reasons. Give a clear rationale so that the coroner can understand why you don't agree with that cause of death. And it ends with the coroner's service. They may well issue, what we now call in this CN1B, and ask the medical examiner, can they help? Can they offer a cause of death? But they may not. They may well say no. Actually, fair point. Inquest or post-mortem is required. But no, short answer to that is no. If you don't agree, say no.
Thank you about that. And the other thing is that suppose send the MCCD to you, and then you advise us to modify, which we are happy with. So do we have to strike that original MCCD and then put the new diagnosis, or should we issue on a different MCCD?
If you can make changes that are going to be kind of neat and legible, absolutely, you don't need to write an entirely new one. I would advise crossing a line through it, signing above where you've made the change. If it's complete structural changes or there's something that's entirely wrong, I would say new one, just to keep things neat and tidy for the registrar.
New one. Yeah, thank you.
Yeah, no worries.
And I think you've probably answered the question that was the last one in the chat, actually. I think that's maybe been addressed. And then I think and I think Jenny is one person, Jenny Jacob, the last person. I think after that we will have to call this to a close because we're getting, well, it is actually 4:30 already, actually. But Jenny, do you want to quickly ask your question?
Yeah, can you hear me, Sam?
Yeah.
So we've had a case recently who this lady had a cardiac arrest, out of hospital cardiac arrest, went to A&E, and she had a return of spontaneous circulation, had a CT, of her head and her neck and was waiting for a consultant review and died in hospital. And the ME called me to ask if I could issue a death certificate because the hospital was not happy to do one. But I had seen the patient with a chest infection several months ago, and I wasn't sure of the cause of death. So she referred the patient to the coroner, and the coroner has come back to us to ask for a cause of death. So I'm just a bit confused what to do now.
I think this case is still ongoing. Dr. Jigger, I think that it's still live because I've chased the coroner's office for an update on it an hour or so before I've called this during this call. So I think if I contact you directly after this and we discuss it outside of the meeting, is that okay?
I think that would be better. Thank you very much for braving the lion's den this afternoon.
More than happy.
You seem to have coped very well with it. Can I just remind everyone, please give us feedback on the PLT. We want to make them as interactive and as, what you want to learn about. But I think this afternoon's been a great afternoon. I hope you agree with me. Good start to the new year. So thank you very much, everybody. Padma, I'm really sorry I've called an end to questions because it is 4:30 and I think we do have to let people go. But I think Sam has said that, queries he will answer, I think, for us. And we're really grateful for his time. And again, just a quick reminder to give us that feedback would be really useful. We've had a great turnout this afternoon, nearly 100 people, so that's fantastic. Thanks very much. And I can see Sam's very kindly put his email in the chat there. So if you any questions you didn't get answered, perhaps it's best to email him. And we will see you on Thursday, the 6th of March.